So start now. Okay, right, fine. I will start it. You need to spotlight the video. Spotlight the video. Okay, it is done. Okay, fine. Okay. Yeah. So good morning. We'll start the session now. Is everybody online? Can we start? Okay, fine. So let us get started with the session. Yes, just a minute. I'll take the screen. Okay, so now the next part of neurology will be about something which is like not only involving the brain. We are going to talk about something involving the peripheral nerves, something involving the neuromuscular junction also. Okay, so before we get into those set of topics, you should know about what is called UMN and LMN. Okay, UMN is upper motor neuron region. UMN, upper motor neuron. That is what is UMN. LMN is lower motor neuron. L for lower. Okay, that is what we say. UMN and LMN. Now we should know first what is UMN and LMN, and then we can discuss about some disorders related to this. Any of you know what is this UMN and LMN? Okay, just for diagrammatic purpose, it's usually discussed in your physiology classes, but because physiology is not yet over, so a little bit about UMN and LMN, I will discuss it here. Okay, so think like this, just a diagrammatic representation. It is not the exact representation, so just for understanding purpose. So think like this. So one area, another area which I'm drawing, and third would be something like this area. This I think many of you should be able to know. It is a cross-sectional view of the spinal cord. Actually, it would appear like this. It would appear like this. Okay, I think you can correlate with what you might have studied in your anatomy classes and all. So this is the cross-sectional view of the spinal cord which I am putting in. Okay. Now think of, for the discussion purposes, think of this upper part as a motor cortex or the brain area. Think of this as a brain. Okay. Think of this as a motor cortex. Motor cortex. Okay, fine. And this area below is the level of brainstem. Is the level of brainstem. Think like this. Third one, as I have just told you, it is the level of the spinal cord region. Okay. Now, what do you call it as upper motor neuron, and what do you call it as lower motor neurons? Any idea? Upper motor neuron and lower motor neuron. Okay. Think about the first tract. What is the first tract? We all know about starting from the motor area. What is that? Corticospinal tract. Okay. What happened? This corticospinal tract will start from the motor cortex area. It will go through the brainstem. And at the level of the medulla, I told you, it will cross over to the opposite side, right? It will cross over to the opposite side. And it will end in something like this structure. It will end in something like this structure. Any of you know what is the structure called? This structure is what we call it as an AHC, or the anterior horn cell. Anterior horn cell. Anterior horn cell. Okay. And from the spinal cord, what happened? The spinal nerve roots will start. The spinal nerve roots will start, and they will go downwards towards the muscles. Correct? This is what generally happens. Okay. Now, in this particular area, in this particular drawing, which is the upper and the lower motor neuron, that is what we need to know. You see here, from the brain area to the level of anterior horn cell. Okay, to the level of anterior horn cell, this is what we call it as a UMN, upper motor neuron. From the brain to the level of the or to the level of spinal cord, that is just above the anterior horn cell, it is called upper motor neuron. Then from the anterior horn cell, the nerve which is arising, okay, anterior horn cell as well as the nerve which is arising from this, that is what we call it as the LMN, or lower motor neuron. This is what is called LMN, or lower motor neuron. I hope you're able to follow this. Okay, this is what is UMN and LMN. Okay, I hope you're able to follow this. Yes, from the brain to the spinal region that is just above the anterior horn cell, it is called upper motor neuron region. From the anterior horn cell, the nerve which is arising from the spinal cord, it is called lower motor neuron. Okay, fine. So this is what is the concept of UMN and LMN. This is one way of looking at it. There is one more way also. What is that? With relation to cranial nerves. Okay, see, what is this tract? This tract is called corticospinal tract, which is what I discussed. Corticospinal tract. Any of you know what is the other one? The other one is called corticobulbar tract. Any of you know about that one? Corticobulbar tract. Corticobulbar tract is again something which starts from the brain region only, okay, but goes to the level of brainstem. Okay, and in the brainstem, you have the cranial nerve nuclei, and from there, the cranial nerve is going to start. Okay, so just try to remember this. From the brain to the brainstem is what we call, again, upper motor neuron. This is what is called upper motor neuron. And what is the name of this tract called from the brain to the brainstem? It is called corticobulbar tract. It is called as a corticobulbar tract. And from the brainstem, you have the cranial nerve nuclei and the cranial nerve which is coming out. You call that as the LMN, lower motor neuron. Lower motor neuron here simply refers to the cranial nerves. Okay, it simply refers to the cranial nerves. I hope you're able to follow this. It simply refers to the cranial nerves. Is that clear, everybody? Able to understand this? Are you able to understand till this point of time? Okay, right, very good. Yes, yes. Right, so this is what it is. You should understand what is UMN and what is LMN. Okay, there are two ways of describing it. One is with relation to corticospinal tract, another one is relation to the corticobulbar tract. Okay, basically, corticospinal tract is the usual one, which we study as UMN and LMN. But corticobulbar tract is something concerned with the cranial nerves, and that also you should make the note of. That is what I'm trying to tell you. Is that clear? Okay, fine. Okay, so that is what it is. Now, generally, you should remember that upper motor neurons, UMN, will have an inhibitory control. They have an inhibitory effect. They have an inhibitory effect on the LMN, lower motor neurons. Upper motor neurons have an inhibitory effect on the lower motor neurons. Please remember this, because when I'm going to discuss about the findings, this point will be discussed again. Okay, right. So just to put it up as a summary, like whoever was joined late, just quickly wanted to tell it again. The concept of upper and lower motor neuron. Okay, upper motor neurons is something which starts from the brain area, and there are two types of upper motor neuron. One is the usual nerve and the muscles. Another one is for the cranial nerves. For the usual nerve and the muscles, the upper motor neuron is the corticospinal tract. Whereas the corticospinal tract, it starts from the motor cortex to the level of spinal cord it goes. This is what is the upper motor neuron. And in the spinal cord, we have the anterior horn cell, and from there, the spinal nerves are also going to arise. That is what is called lower motor neuron. Okay, this is the usual UMN and LMN we know of. There is one more also which you should make a note of, which is from the corticobulbar tract, which is concerned with the cranial nerves. What is that? From the motor cortex goes to the level of the brainstem, and from the this is the upper motor neuron, which is nothing but the corticobulbar tract. And from the brainstem, you have the cranial nerve nuclei, like the facial nerve nucleus and all. And from there, the facial nerve and the other nerves are going to arise, and this is what we call it as an LMN here. I hope in this point it is clear. Fine. Okay. So that's about the concept of UMN and LMN. And I was telling you the last point that upper motor neuron always have an inhibitory control over the lower motor neurons. Okay. Fine. Now, there are some conditions which can involve the upper motor neuron and some conditions which can involve the lower motor neuron. Now, based on whatever I have discussed till this time, you people try to tell me stroke is an example of which upper motor neuron or lower motor neuron. Stroke. Okay, stroke is an example of upper motor neuron or lower motor neuron. Any comments? Stroke I had discussed yesterday, correct? Stroke I had discussed yesterday, whether it's upper motor neuron or a lower motor neuron lesion. Stroke is something which was involving the corticospinal tract, correct? Corticospinal tract. Corticospinal tract is an example of upper motor neuron. So stroke is a typical example of UMN lesion. Okay, correct. Stroke is a typical example of UMN lesion. Okay, correct. Very good. Some of you are answering it correctly. It's an example of UMN lesion. Okay, now let us quickly know about the differences between the two types of lesions. Both lesions, what happens? Obviously, the nerves are affected. When the nerves are affected, you will get weakness. Okay, you will get muscle weakness. Obvious thing, right? But what type of muscle weakness? The paralysis here I am talking about is the muscle weakness. I am talking about the muscle weakness. What is the type of muscle weakness or the paralysis you will get? Please remember, I told you. Understand this concept. It is with relation to the tone. I am talking about with relation to the tone. Normally, remember which type of neurons will control the tone. Both the neurons will control the tone, but which is in direct contact with the muscle. Lower motor neuron is in direct contact with the muscles. Okay, and always remember upper motor neurons have an inhibitory effect on the lower motor neuron. That is what I was telling you. Now think, if the upper motor neuron is damaged, that is what we talk as upper motor neuron lesion. What will happen? The inhibitory effect of the upper motor neuron on the lower motor neuron is lost. So there is nothing to inhibit the lower motor neuron. So the lower motor neuron will keep on exciting the muscle. And you tell me what will happen to the tone of the muscles. Very, very simple. What will happen to the tone of the muscle? Yes, the tone of the muscle will increase. The tone of the muscle will increase. Simply because upper motor neuron is gone, it is damaged. So lower motor neuron will keep on exciting the muscle, and it will increase the tone of the muscles. And this is what we call it as spasticity. This is called as spasticity. This is called spasticity. Okay, right. Whereas if the lower motor neuron is affected, see, lower motor neuron is the main control for the muscle, right? The lower motor neuron itself is gone. What will happen? The muscle tone also will be decreased. The muscle tone will be decreased. Okay, this is what we call flaccidity. This is what is called flaccidity. Okay, are you able to follow this, right? So this point, I hope you are able to understand this, right? Okay. Then muscle atrophy. See, I told you lower motor neuron only is in contact with the muscle. So muscle atrophy will be a feature of LMN lesions. Muscle atrophy will be a feature of LMN lesion only. And the human lesion, usually there is no muscle atrophy. Very, very late stages, you can have atrophy by not using the muscle. But initial stages, muscle bulk is preserved. But muscle atrophy is a prominent feature of LMN lesions. Okay, right? Okay. Then deep-tendon reflexes. This is also has got a, strong correlation with physiology. Right now, I will just tell you the point only. Later in your physiology classes, you will learn the detailed explanation. Deep tendon reflexes are something which are under an inhibitory control from the upper motor neuron lesions. Lower motor neuron only coordinates, but it's under an inhibitory control. What will happen if the human lesion is occurring? Upper motor neuron inhibitory control is gone. So the lower motor neuron will keep on exciting the muscles and the reflex arc, and that will result in exaggerated reflexes. I'm going to put like this. 3 plus means that it's an exaggerated reflex. It's an exaggerated reflex. Okay. Exaggerated refers to what? Exaggerated refers to absence of inhibitory control of the UMN over the LMN on deep-tendon reflexes. Okay, right. How about LMN lesion? LMN is the main thing which is concerned with deep-tendon reflex. When LMN is getting damaged, obviously the deep-tendon reflex will be absent. It would be absent deep-tendon reflex. Able to follow this? Okay, right. Then fasciculation of fibrillation. Okay, what is the idea about fasciculation of fibrillation? Fasciculation of fibrillation refers to small irregular contraction of the muscles. Small irregular contraction of the muscles. Okay, irregular contraction of the muscle groups. Now this is normally not happening. Okay, you think like this. You are just simply keeping your hands. If your muscle starts contracting inside, then you call it as fasciculation of fibrillation. Normally, none of us will have that fasciculation of fibrillation. It is something like under an inhibitory control from lower motor neuron. Okay, you think like this. The nerve roots, they inhibit the muscle generally. So that fasciculation fibrillation will not occur. When lower motor neuron tends to get damaged, what will happen? The muscle will show these irregular action potentials or irregular contractions. That is what we call it as fibrillation or fasciculation. So presence of fibrillation and fasciculation is a feature of lower motor neuron lesion. This is something important. Okay, right? So again, I will repeat that concept. The concept is muscles, they have an irregular potential, irregular action potential, okay, which is not normally occurring because they are inhibited by lower motor neurons. Okay, so when lower motor neuron get damaged, muscle will keep showing up those irregular action potential, which will manifest as small contractions. That is what we call fasciculation of fibrillation, which is always a feature of LMN lesion. Fasciculation fibrillation are not going to occur in case of UMN lesions. Okay, right. Then Babinski sign. This again is from your physiology things only, right? I'm not going to discuss this Babinski sign now. You will learn in your physiology classes. Okay, I will just tell Babinski sign is positive in UMN lesion, Babinski sign is negative in case of LMN lesion. Okay. If I go into the details, it will be a long discussion, so that is why I'm purposely avoiding it now. Okay, right? You can learn in your physiology class what is Babinski sign. But I think other things you're able to understand. Okay, fine. Okay. The first 3 things are the ones which are definitely very important. The first 3 things: type of muscle paralysis, muscle atrophy where you get, and deep tendon reflexes where you see exaggerated and where it is absent. I hope you're able to follow this. Clear? Okay. So these are the typical differences between UMN and LMN lesions. Please know about the concept of UMN, concept of LMN, and then what are the manifestations of each of these lesions. Okay. Yes. Fine. So let us move on to the next one. Next one will be about some conditions which we are going to start with. The first one I'm going to start with is something called motor neuron disease. Okay, motor neuron disease. Okay, now motor neuron diseases, there are so many types. Okay, we were talking about upper and lower motor neuron, correct? Something affecting those areas. That's all. Okay. Now the point which I want you to remember is there are so many conditions under motor neuron disorders, but the best example and the usual one which is asked for your exams is always about something called ALS, amyotrophic lateral sclerosis. Okay, amyotrophic lateral sclerosis. I would like to, put up one example of a person who was suffering from this disorder. Okay, and like there was something like very famous things which were happening at that time also. So I think all of you know him. Who is he? Who is he? Yes, he is Stephen Hawkins. All of you know about him. He is he's one of the persons who had suffered from this particular disorder. And I will try to correlate few things once I am finished with the topic of amyotrophic lateral sclerosis. Okay, right? And any of you know what is that picture below? Any of you know what is this picture below? something related to, it was a little famous sometime back, not now, something called ice bucket challenge and all, where they used to pour this, where they used to pour this bucket of ice, okay, right, as a challenge, and take it up as a challenge. And if they cannot do it, they have to contribute to that foundation which was working on amyotrophic lateral stenosis. Okay, right? So that was the importance of this. Anyway, I'll come back to all these things a little later. The condition which I'm going to discuss about is amyotrophic lateral stenosis. Okay, fine. So what is this condition first of all? Amyotrophic lateral sclerosis. Okay, it's a condition which is a neurodegenerative disorder. Okay, it's a neurodegenerative disorder. It's a neurodegenerative disorder. Yesterday I told you so many neurodegenerative disorders like Alzheimer's disease, Parkinson's disease also. This is a neurodegenerative disorder which is characterized by progressive death of the neurons. Okay, progressive death of the neurons. Progressive death of neurons. The point to be noted is there's only motor neurons which are affected. Sensory neurons and all is not affected. It is the motor neurons which are affected. And this is a disease which is characterized by death of both UMN and LMN. So that is the point. It affects both upper motor neurons as well as lower motor neurons. This is important. It affects both upper motor neurons and lower motor neurons. Okay, right? It is not only UMN affected, only LMN affected. No, both brain, spinal cord, everywhere you can have the problem. That is what I'm trying to tell you. Now, the manifestation depends on what type of lesion occurs in the whenever we talk about motor activity, we are mainly talking about limbs, upper limbs and lower limbs. That is where we talk about motor activity, right? So let me tell you the findings with relation to motor part of the limbs, okay, or movement of the limbs. Okay, right. In upper motor neuron, it is LMN type of lesion which usually occurs. Please remember, in upper motor neuron, LMN type of lesions will occur. That means lower motor neurons are predominantly affected in the upper limb area. And in the lower limb, UMN type usually occurs, upper motor neuron type. So you can see it is a reverse of this thing, right? In upper limbs, LMN type of lesion, that is lower motor neuron type of lesion. And lower limbs, upper motor neuron type of lesions are usually occurring. Okay, just like the rule. It can be the other way also. Okay, many texts are given it in other way, but still, I just wanted you to remember the general rule. Okay, so if LMN will be the finding in case of upper limbs, what do you think would be the features? Just quickly tell me what will happen to the muscle bulk in that area. What will happen to the muscle bulk in that area? Muscles will undergo atrophy. What will happen to the tone of the muscles? It would be decreased. What will happen to the deep tendon reflex? It would be absent. You can just quickly write it. Whatever we have discussed above only, right? Tone will be decreased, or what is called flaccidity. Deep tendon reflexes will be absent, and you will get muscle atrophy. Definitely, you will get muscle atrophy. Of course, fibrillation also can be present, but I'm writing the main features. Okay, whereas in the lower limb, what will happen? Exactly opposite. It's a human lesion, right? So tone will be increased. Deep tendon reflex plus, meaning exaggerated deep tendon reflexes, and muscle bulk is usually normal. Okay, it is not atrophy. Okay, right? So that is what I'm trying to tell you, right? Just make a note of it. That's enough. Okay, right? Upper limbs LMN, lower limbs it is more of UMN. Okay, right? Okay. Now, what are the other areas where you can have problem? Okay. See, I told you the concept of UMN and LMN applies to cranial nerves also. So cranial nerves also can be affected, and predominantly the 9th and 10th cranial nerves are affected. Think like this: 9th and 10th cranial nerves are affected. What are the 9th and 10th cranial nerves? Glossopharyngeal nerve and the vagus nerve, which are all concerned with the what things? Okay, nasopharynx, oropharynx, larynx. All those areas will have a problem. So what manifestation typically they can have? They can have difficulty in swallowing. What is that? Dysphagia can be present. They can have difficulty in speech. What is that? Dysarthria can be present. All those things can be there. Okay. Dysphagia, dysarthria, all those things, okay? Difficulty in swallowing, difficulty in articulation, all these things can be present. It is due to involvement of 9th and 10th cranial nerves. Okay, now, what about sensation? What about mentation? What about bowel or bladder function? Will it be affected or not affected? Affected or not affected? Completely normal. Because please remember, this is a disease of motor neurons, not involving the sensory or other areas, right? So sensation will be normal, not affected. Mentation, that is the higher mental functions, they also will be normal. In fact, if you look at the patients, IQ is normal. IQ is normal. The typical example is Stephen Hawking. I think all of you know. We have to agree that his IQ was much higher than most of our IQ, right? Because he was able to describe so many things. You might have noticed that, right? Due to the limb weakness and all, he was actually confined to the wheelchair only. But with the wheelchair, he was able to do so many things. He was able to think about so many things which most of us could not even have imagined also. Okay, I think all of you know about him. So he's the best example. that IQ is not affected. In fact, higher mental functions or the normal functions are not affected. Okay, right? Bowel and bladder function also is normal. It is not affected. Okay, even sexual function is also normal. So what is the point I'm trying to tell you? The patient cannot move his upper limbs and lower limbs at all, but he will be very, very aware of what is all happening around him. Okay, he will not be able to move around by himself because his limbs are paralyzed. But sensation will be normal, his thinking will be normal, everything else will be normal. That is what is a classical description. What is a classical description? You can see patient feels trapped inside his own body. Means he cannot come out of it. Means he's not able to move around. Okay, but still he knows whatever is happening around him. That is what is the meaning of patient feels trapped inside his own body. A very, very classical description. So all these are important findings of amyotrophic lateral sclerosis, which you should be aware of. Is that clear, everyone? Are you able to understand this? Right? Okay, fine. Now, amyotrophic lateral sclerosis is a neurodegenerative disorder. Okay, I have told you this. Neurodegenerative disorder is something which you cannot cure the patient. Okay, right? We can only supportively try to manage the patient. We cannot make them survive for a long period of time. Only supportively you have to manage it. Okay, right? And do you know what is the cause of death in this patient? You know what is the cause of death in this patient? I told you the 9th and 10th cranial nerves are affected, right? So the swallowing and all will become impaired. So as the disease is progressing, they cannot even swallow properly. And every time you try to feed this patient, they will vomit out or they will not be able to swallow it properly. And at the time of vomiting and all, what potential problem can occur? They can have recurrent aspiration. Very, very important. They can have recurrent aspiration. Aspiration means it is going into the respiratory tract and into the lungs. And finally, it will lead on to progressive respiratory failure, which will be the cause of death in this patient. This is an important MCQ question. What is the cause of death in a patient with amyotrophic lateral sclerosis? Important MCQ question. It is respiratory failure. Okay, it is a respiratory failure. Okay, please keep in mind. This is important. It is a respiratory failure, which is the cause of death. Okay, again, we cannot cure this particular condition. We can only symptomatically treat it. So many research went into how to bring about improvement in a patient's life with amyotrophic lateral sclerosis. Okay, that is why this type of ice bucket challenge and all was started, just to take up that particular challenge. And if you're not able to take up the challenge, you should contribute to the ALS Foundation, okay, which was like a research foundation to fund that particular research for treatment in case of ALS. That is what is the importance of this ice bucket challenge. And after so many research, they found out that one drug which can particularly be helpful is rivastigmine. I have already told you this. Rivastigmine yesterday itself. Where did I discuss this rivastigmine? One of the acetylcholinesterase inhibitors. And this rivastigmine is found to delay the apoptosis of motor neurons. Nobody knows the exact mechanism, but it is found out that it delayed the apoptosis of the motor neurons, thereby prolonging the life of the patient in amyotrophic lateral sclerosis. One more drug which is also found to be useful, it is a new drug. Again, the mechanisms of action that you don't need to worry about. Just remember, it is helpful in a patient with motor neuron disease. What is that? Riluzole. And if I'm not wrong, this has already been asked in your exams. Okay, I have not seen the question directly, but one of the students said that it came in one of the recent exams. I think 2021 exam, that question came. Riluzole is a drug which will be useful in the management of which of the following conditions, like that. Okay, right. It is motor neuron disease. Okay, right. Nobody knows the exact mechanism. It is just a fact which you have to remember. Clear, everyone? Okay, right. So that is about the topic. Yes, that is about the topic of amyotrophic lateral sclerosis, which is the best example of neurodegenerative disorder involving the motor neurons. Don't forget one thing, only the motor activity is affected. Every other thing is normal, like sensation, mentation, IQ, bowel, bladder function, everything is absolutely normal in a patient with amyotrophic lateral sclerosis. This is the point which you should keep in mind. I hope this is clear. Everybody able to follow this? Okay, right. Okay, so that's about this one. Okay, next we move on to something called as diseases which are involving the motor unit. Okay, this is again a physiology concept. What is the meaning of motor unit? Okay, what is that? Just a minute, 1 minute, please give me a minute. Just a minute, 1 minute. Okay, that's a small problem. Okay, you all tell me, have you all received that questions which I have shared little late? Sorry, I could not share it in the evening. It was little late. I sent all the questions to coordinators. Just let me know whether you have received the questions, whether you have received the questions in CNS. I have also sent all the PDFs of the images in respiratory system, images in neurology, as well as the annotated MCQs in respiratory system. Okay, some of you are saying received, some of you are saying not received. It's like how some will receive and some will not receive. Okay, I will just ask them to share again. I'll just ask them to share again. I think Pooja is saying that she's not received. Okay, I'll just try to tell them, okay, to share it with you all. Okay. Okay, it came in the main WhatsApp group. Okay, fine, fine. So please check your groups once again. And still, if it is not received, okay, right, let me again remind them. Okay, I will again remind them. Okay, done. Fine. We will move on to the next topic. Okay. Right. Okay, okay. They have put it in the WhatsApp group, so please check it out, everyone. Okay. All right, all right. Okay. So, yes, let us get started with the next set of disorders. Yes, yes. Okay, okay. Fine, fine. Okay, right. Good. Okay, so let us start with the next set of disorders, which will be related to the motor unit. Okay, which will be related to motor unit. This is something like a unit which is composed of nerves and muscles. Simply, if you want to put it, it is nerve and muscle. Can you see that? The first area, this full area is about the nerve, and the last area is about the muscle. And in between, you have a neuromuscular junction also. NMJ, if you want to remember the simple word, neuromuscular junction also. This area. Okay, neuromuscular junction. This complete thing is what we call it as a motor unit. Okay, nerve, neuromuscular junction, as well as muscles. Now tell me, what is this area which we are talking about? Is it a human area or a element area? Is it a human area or a element area? Is it a human area or a element area? Simple question. It is a spinal nerves along with the muscle. It is a element area. So whenever we talk about any disease which is involving the, whenever we talk about any disease involving the nerve, muscle, or neuromuscular junction, it is mainly a type of lower motor neuron type of problem. Okay. However, there is a small difference between the neuropathy and myopathy. Neuropathy means only the nerves, myopathy means only the muscles are affected. There is a small difference between the two, which I am going to enumerate. Okay. See, in both type of neuropathy and myopathy, you will have weakness without any question. There will be weakness of the muscles. However, in neuropathy, it is the distal muscles which are more affected. Distal group of muscles which are more affected. You write it, I will explain it. Myopathy, proximal group of muscles are more affected. Proximal group of muscles are more affected. In myopathy, proximal group of muscles are more affected. What does it mean? Very, very simple. Suppose I'm taking the upper limbs. Imagine I'm taking the upper limb. If it is a neuropathy, the distal muscles will be affected. What are the distal muscle? Distal muscle means the hand muscle or the finger muscles, palm muscles. That is what is affected. That is a distal muscle weakness. If it is a myopathy, it is a proximal muscle. What is the meaning of proximal muscle? In the hands, in the limbs and all, it is the shoulder muscles which are affected. If it is the lower part, it will be the hip muscles which are affected. I hope you're able to understand this. Proximal and distal. Neuropathy is predominantly distal muscles. Myopathy is predominantly proximal muscles which are affected. That is the point to be noted. Fasciculation, I told you, fasciculations are something which are generated in the muscles. So when muscle is damaged, there won't be any fasciculation. Whereas fasciculation would be a common feature of neuropathy. That is the point which I wanted you to remember. Fasciculation is a common feature of neuropathy. Deep pendant reflexes, I told you, they are usually absent in case of myopathy, in case of neuropathy. Myopathy won't be completely absent. It would be present, but it would be like sluggish. Because anyway, if a reflex is going to be elicited, the muscle should start contracting. Myopathy, what will happen? Nerve will be okay, but the muscle will not contract properly. That is why I'm saying deep pendant reflex may be present, but it is sluggish. That is what. Obviously, sensory sign will be present in where? Neuropathy or myopathy? Obviously, you can have sensation only carried by the nerves. So, sensory signs are present in case of neuropathy. That means loss of sensation will be present in case of neuropathy, whereas sensations are not even affected in case of myopathy. When I write, it is not that sensations are present. No, sensory signs means what I'm talking about is loss of sensations. Don't forget. What I'm talking about is the loss of sensation. Okay, what I'm talking about is the loss of sensations. Are you able to follow this, everyone? Yes? 1 minute. Yes. Okay. Doctor, and one more thing I wanted to clarify is some of you are saying you have not received the workbook. See, workbook has been shared well in advance, even before the class started. So those who have not received the workbooks and all, there is, like you have to ask your coordinators for them, okay, because I've shared it well in advance. Okay, right. So these are the differences between neuropathy and myopathy. Is that clear? Okay, right. So just make a note of the differences between the two. Just remember this. Okay, fine. Now we are going to look at some examples of neuropathic disorders mainly. Okay, myopathy I'm not discussing much, not important for the exam. What I am discussing is mainly about the neuropathic disorders. Okay, Neuropathy means, look at this particular picture. This is a picture of a nerve, and this is normal, and this is something which is a damaged one. What is that we are talking about? Can you see the damaged area? All these areas of the damaged area. What is that? Something like a covering of the nerves. What is the covering of the nerves? It is nothing but the myelin. So we are going to discuss about conditions wherein you have a damaged myelin. Damaged myelin. What is the role of myelin? What is the normal role of the myelin? Normal role of the myelin is that it helps in conduction of nerve impulses. I think all of you know. Okay, myelin helps in the smooth conduction of nerve impulses. Okay, so when myelin is going to be damaged, what is going to happen? The conduction of the nerve impulses will become slow. Nerve conduction will become slow. I hope you are able to follow this. This is the main problem where the nerve conduction will get affected. Are you able to follow this? So this is the usual problem whenever you talk about a disorder of myelin. The main problem is nerve conduction gets slowed. That's all. Okay, and there are two important examples of disorders involving the myelin. Any of you know some examples? We call them by a name as demyelinating disorders. Demyelinating disorders. Any of you wants to comment on this? Demyelinating disorders? Yes, anybody? Demyelinating disorders? Disorders involving the demyelinating disorder. Any examples? Anybody wants to comment? Two things are there. One is the very famous one. Even this time in your January exam, we had a question. What is it? GBS. What is that? Guillain-Barré syndrome. Guillain-Barré syndrome. Guillain-Barré syndrome. Number one, GBS. Number two, yes, multiple sclerosis. Multiple sclerosis. Notice there are many disorders which are affecting the myelin. I think I am reading the answers. I can understand that you are saying some of the other disorders involving the nerves as such. That is all okay. But I am asking about something called demyelinating disorders where the myelin sheath becomes damaged. That is what I was talking about. I'm not talking about any tumors and all. Just talking about a demyelinating group of disorder. Two things I've written. GBS and number two is multiple sclerosis. That is what we are going to discuss about. GBS was this January exam topic also. Okay, right? There was one scenario-based question on a Guillain-Barré syndrome. Okay, fine. So let us start with the first one. See, first thing I wanted you to remember is Guillain-Barré syndrome is more of an acute condition. And multiple sclerosis is a recurrent condition, means multiple episodes it will have. Guillain-Barré syndrome usually only one episode and that too acute presentation, whereas multiple sclerosis is something which is over a long period of time and it will have recurrent episodes. That's what you need to remember. Let us get started first with the Guillain-Barré syndrome. Okay, and I have written something like a name, something like a term for this also. What is that? AIDP. Okay, any know? What is the expansion of this AIDP? Any idea? AIDP. AIDP stands for an expansion acute, please remember, acute inflammatory DP, demyelinating polyneuropathy. Demyelinating polyneuropathy. Please make a note of this. AIDP, acute inflammatory demyelinating polyneuropathy. AIDP. Okay, fine. Okay, now what is this condition first of all? Okay, I have already put a small note about this. It's a post-infectious condition. Okay, please know this, doctors, right? For your exams, these post-infectious conditions are something which are very popular in your MCQs. One or two conditions I'm discussing in this set of internal medicine discussion. Okay, few other conditions you must have heard in your pediatric classes like PSG and post-streptococcal glomerular nephritis and all. All those post-infectious conditions are something which are very important topics for your exams. Okay. In renal system, they teach you about something called hemolytic uremic syndrome. That is also a post-infectious condition. All these post-infectious conditions are something which are favorite topics for national board examiners, so you should know about this. Okay, right. Do you know what is the usual infection which is preceding this particular GBS? Do you know what is the most common infection? Most common infection, which is a trigger for this? It is a gastrointestinal infection, GI, gastrointestinal infection. And if you know about what is the organism, it is Campylobacter jejuni. It is Campylobacter jejuni organism. Okay. GID means what type of infection I'm talking about. I'm talking about something like a diarrhea, but this is not only diarrhea. This is a diarrhea with blood and stools. What do you call that? Diarrhea with blood and stools. What do you call that? Dysentery. It is more of a dysentery type presentation. The patient will not only have loose stool, there will also be blood in the stools. Okay, and that organism which is commonly implicated is Campylobacter jejuni. So what happens? First, the dysentery occurs. Later means like few weeks, typically 1 to 3 weeks later, the patient will have myelin damage. So that is why, can you see, it is a condition not occurring together with the infection. It is occurring late after an infection. That is why I have told you it's a post-infectious condition. Any of you know how this myelin gets damaged? The myelin gets damaged by the antibodies. See, I think all of you know, whenever there is an infection, there will be presence of bacterial infection we are talking about. There will be presence of bacterial antigens. Against the antigen, what the body will produce? Body will produce antibodies. Normally, the antibodies should attack only the antigens. But here, these antibodies are also attacking the body's own myelin. What do you call this? It is simply because some of the antigens or some of the structure of the myelin resembles that of the antigen itself. So that is why antibodies falsely remember this myelin as the target and they start damaging them. So what I'm trying to tell, myelin structure and the antigen structure of the bacteria resemble each other. That is why antibodies are confused and they start attacking the myelin itself. What do you call this? This is what you call it as a concept of molecular mimicry. Because the myelin structure mimics that of the Campylobacter antigen, bodies will start attacking them. This is called as molecular mimicry. And you should know for your exam what is the name of the antibody. And if you know the name of the antibody, it is a very important. I'm putting a star. It's a famous question also. Anti-ganglioside antibody. It is anti-ganglioside antibodies. Please keep a note of this. This is important. It is anti-ganglioside antibody. Is that clear? So please make a note of it. It is anti-ganglioside antibody. Clear? Okay. So what I have told is just a simple approach to that this thing, right? Simple way of remembering what goes wrong in case of Guillain-Barré syndrome. That's all. Nothing much I have told. Now we move on to the features of this particular condition. Obviously, it's a neuropathy. If it is neuropathy, you should have weakness of the muscles. What is the type of weakness? Okay, what is the type of weakness? The name, first of all, you should remember, it's an acute condition, I told you. And what is the weakness? I told you if it is element weakness, the tone is decreased. What is the name for decreased tone? Flaccidity, I told you. The name for decreased tone is flaccidity, right? Name for decreased tone is flaccidity. And this is called acute flaccid paralysis. This is called acute flaccid paralysis. Please don't forget this. Make a note of this. This is a very famous term actually. Acute flaccid paralysis means it's an acute condition characterized by flaccidity. First of all, you should know what is the flaccidity. What is the meaning of flaccidity here? What is the meaning of flaccidity? Sorry, flaccidity is okay. It is decreased tone. That is fine. What is the meaning of acute? Acute is something like a duration of up to 4 weeks. Please remember, this is what is the meaning of acute. Okay, this is what is the meaning of acute. Just a minute. I'm sorry. Right. So acute is something which is a duration of up to 4 weeks. Okay, please make a note of this. Okay. Now, what is a typical? Yes. What is a typical description of this acute flaccid paralysis? Okay. I will tell you this, then I will make you write it. It's something like this. The patient will start having weakness, which is from the lower part of the body, typically the lower limbs. Okay, and that to the lowermost part of the body to begin with, because it's a neuropathy. I told you neuropathy usually involves the distal group of muscles. So if you talk about the limbs, what is the distal group of muscle? It is the foot muscles, where you think like this. One fine day, the patient wakes up from the bed. He says that, doctor, I'm having difficulty in putting the slippers or the chappals. I'm not able to hold on to the slippers properly, right? When I'm walking, it is repeatedly slipping off from my foot area. That is how they typically start. Means the lower part of the lower limbs is getting affected first. Then what happens? Slowly, it will start progressing upwards. That means maybe like few hours later or 1 day later, what you will say, doctor, I'm having weakness in the leg also. I'm not able to stand properly from the sitting position or the lying down position. Whenever I stand, I feel weak. That is what they say. Then it will involve the hip muscles. Then the patient will say, like, I'm not even able to sit properly also. So what I'm trying to say, it starts from the lower limb and slowly starts ascending upwards. Okay, so this is what you have to remember. It starts in the lower limbs. And that to the foot area. And then it shows upward progression. Are you able to follow this? Starts in the lower limb and will start moving upwards. It will show an upward progression. Are you able to follow this? And this type of weakness is something which is very characteristic. And if you know what is the name of this weakness called? name of this type of weakness? It's a very famous term. Upward means what? Ascending or descending? Upward means ascending or descending? It is ascending. So it's basically an ascending paralysis. And the name of this is after the person who described it, called as Landry's ascending paralysis. Please make a note of this. It's called Landry's ascending paralysis. Okay, so please do make a note of it. It is very important name. Starts from the lower part and then goes upwards. Okay. And one more point which I wanted to add is this is a condition which is usually symmetrical, bilaterally symmetrical. So when I say lower limbs are affected, both lower limbs are affected equally. That is what I'm trying to say. Both lower limbs are affected equally. Are you able to follow this? It's a bilateral symmetrical condition. Okay. Now, any of you know any other condition where also you get this, what to say, ascending paralysis? Any other condition also, do you have paralysis starting from the lower part and going upward? Any idea? And that is also an acute paralysis. Acute paralysis. The clue is it is one of the infections, and that infection has now been eliminated in our country. India has been declared a few years back itself free of that particular infection. What is that? I think all of you must be knowing about this. Poliomyelitis. It is poliomyelitis. Okay. What I'm trying to say, poliomyelitis is also a condition which can be manifesting as acute flaccidity. It can also manifest as acute flaccidity. But there are certain differences between Guillain-Barré syndrome and poliomyelitis according to the pattern of weakness. This is an important MCQ question. Of course, we are not getting cases nowadays because India has been declared polio-free. But still, for an MCQ purpose, you should know the differences between the manifestations in Guillain-Barré syndrome and poliomyelitis. I will make it like a small table. I'll make it like a small table. Difference between GBS and poliomyelitis. What type of weakness? What is the type of weakness? Both are examples of AFP. That means flaccid paralysis. Both GBS as well as poliomyelitis, both will have flaccid paralysis only. But Guillain-Barré syndrome, I have just told you, it is a symmetrical weakness. It's a symmetrical weakness, whereas poliomyelitis, it is asymmetrical. Don't forget this. Poliomyelitis is asymmetrical. Next thing is, 1 minute. It's not showing up. Just a minute. Okay, now it's coming. Okay, poliomyelitis is asymmetrical. Okay, next thing is sensory involvement. Sensory involvement. Where is sensory involvement noted? Sensory involvement is noted in Guillain-Barré syndrome, whereas sensory involvement is usually not a feature of poliomyelitis. Okay, it is not a feature of poliomyelitis. Third important thing is fever. Fever at the time of presentation. Obviously, Guillain-Barré syndrome is a post-infectious condition, so you will not have fever at the time of weakness. Whereas in poliomyelitis, along with the infection, the weakness also starts. So you will have fever at the time of presentation. So these are the differences between Guillain-Barré syndrome and poliomyelitis. Okay, please keep a note of this. Yes, very good. Not malaria, doctor. Poliomyelitis typically has this flaccid paralysis. That is what we are discussing. Okay, fine. Is that clear? Right. So I just wanted you to remember about this because this is something which you have to remember correctly because sometimes in your exams, the question will be in such a way that you have to make a difference between GBS and poliomyelitis. That is why I want you to know about this. Clear, doctors? Fine. Okay, so this is the main feature of Guillain-Barré syndrome, which is flaccid paralysis. Okay, involving the muscles. That is what, or involving the motor nerves. That is what we are talking about. But look at the definition. Sorry, look at the wording. What is that? Guillain-Barré syndrome is not only involving one group of muscle. It is a polyneuropathy. What is the meaning of polyneuropathy? Multiple nerves, group of nerves are getting affected. Any idea what is the meaning of polyneuropathy here? I'll write it by the side. Polyneuropathy. In addition to motor nerves, what other nerves can be affected? Just now I told you, sensory nerves can be affected. Autonomic nerves can be affected. Okay, autonomic nerves can be affected. Even cranial nerves are also affected. So that is why this term is important. It is called polyneuropathy. It is called as polyneuropathy. Okay, it is called polyneuropathy. Correct? Remember to follow this, right? Okay. So what are the other manifestations? That is what we are going to discuss. What are the other manifestations of this particular condition? Okay, I have told you cranial nerves are affected. Definitely, I'm writing plus means they can be affected. The most common cranial nerve affected is the seventh cranial nerve or the facial nerve which is affected. It is the facial nerve. Most common cranial affected is the facial nerve. Sensory disturbances also is a feature of this particular condition. Like for example, they can have something like an abnormal sensation, like tingling sensation, or they can have absence of sensation from one area itself. What do you call that? Numbness in that area. So all these are manifestations. I'm just saying sensory manifestations are present. Autonomic disturbances also will be present. And these autonomic disturbances are something which are related to the heart rate, blood pressure, respiration, something like that. So how does it manifest? You may have admitted that patient in the ward. And as you keep observing this patient, you will notice that the heart rate is fluctuating greatly. At one time it was 70, another time it was 90. Then again it came back to 70, again it is increasing to 90. So it's a fluctuating heart rate. Or something like blood pressure keeps on varying, something like that. So that is what I'm going to write. Sudden changes happens in the heart rate, blood pressure, all those things. Okay, that is what we call it as the autonomic disturbances. That's what I'm trying to say. Autonomic features would be present. Now, for your MCQ purpose alone, this is something which is important. I'm putting a lot of stars there. What is that? Which features are usually not a part of presentation in Guillain-Barré syndrome? One thing I told you as a differentiating point from polymyelitis. What is that? Fever is usually not a feature. Next important thing is bowel and bladder disturbances. Bowel and bladder disturbances are not a feature. Bowel and bladder disturbances are absent. Something like what? Constipation, urinary incontinence, like that, it won't be present. That is what is the point. Okay, right? So this is important for your exam because I have seen good number of questions like this. All are features of Guillain-Barré syndrome, except like that questions that come. So that is why these two negative points you should know about. Okay, fever is absent. Bowel bladder disturbances are also absent. That is what you should remember. Okay, clear? Are you able to follow this, right? Okay, so these are the main characteristics of Guillain-Barré syndrome, which you should remember. Just a quick review. We'll know what we have discussed. It's a post-infectious condition. So at the time of presentation, fever is not absent. Whereas in case of poliomyelitis, at the time of presentation, fever is present because it's an infectious condition. Second thing, Guillain-Barré syndrome is characterized by ascending bilateral symmetrical paralysis, whereas poliomyelitis is characterized by asymmetrical paralysis. And Guillain-Barré syndrome is a polyneuropathy. So in addition to motor nerves, multiple nerves, including sensory, cranial, autonomic nerves are also affected. This is the essence of clinical aspects of Guillain-Barré syndrome, which you should remember. Okay, fine. So now other things are all just one-liner points which you should definitely know about, which is the overall best investigation for diagnosis of this condition. See, I told you, what is the problem? Myelin is getting damaged. Okay, when the myelin is getting damaged, what is the problem? I told you, nerve conduction is becoming slow. That is why there is weakness of the muscles. So whatever it is, all these group of neuromuscular disorders, okay, they are finally going to affect the muscle. So if you can look for the, activities in the muscle, it can give you a clue as to what type of disorder you are dealing with. So any of you know what is the best investigation for all these neuromuscular disorders? Most of these disorders, it is something called EMG. EMG. What is EMG? Electromyogram. It is the overall best investigation. Please remember this. Complete of name of that is, what do we do is, we'll take only one particular muscle group supplied by one nerve fiber. So it's called single fiber EMG. Single fiber electromyogram. I'm putting a lot of stars for this because this is one of your important MCQ questions asked many times in the exam. Single fiber electromyogram is the most or the best investigation for this neuromuscular disorders, including Guillain-Barré syndrome. Please keep in mind. Okay, fine. You don't need to know the findings in electromyogram. Nobody is going to ask you that, but the name you have to remember it. Okay. Next one, purely for academic purposes. Purely for academic purpose, nobody is going to do this investigation. What is that? CSF analysis. See, doctors, you remember one thing. Yesterday also I told you, subarachnoid hemorrhage, CSF analysis. Can you recollect xanthochromia? I told you, but I told you nobody is going to do the CSF analysis for subarachnoid hemorrhage. Same thing. Nobody is going to do the CSF analysis for Guillain-Barré syndrome also. But purely for academic purpose, you have to remember. Always remember, as an investigation, CSF analysis is done only in one disorder, if you suspect. What is that disorder? CSF analysis is a routine investigation for only one condition. What is that? Meningitis only. It is for meningitis only, right? All the other things that I'm saying about CSF analysis is purely for academic purposes. Please remember in mind. Okay, so if you do the CSF analysis, actually in the first week of illness, it is not going to be there. Usually in the second week of illness. Please remember. That's what textbooks very clearly say. Second week of illness. Okay, if you do the CSF analysis, you can get some characteristic findings. Any of you know some findings? Any of you know some findings? Okay, see, it is an inflammatory condition, right? Acute inflammatory polyneuropathy, inflammation. Due to inflammation, the protein levels in the CSF will be increased. Protein levels in the CSF will be increased. It is basically due to inflammation. Very simple. It's basically due to the inflammation. Okay. basically due to inflammation. What do you think will happen to the cell count? What do you think will happen to the cell count? The cell count is absolutely normal because remember, cell count means I'm talking about WBC, like lymphocyte, neutrophils, and all. Where will the cell count be increased? Cell count will be increased in the case of meningitis or an infection. This is not an infectious condition, it's a post-infectious condition. So the cell count is normal. So can you see that there is a discrepancy between the cell count and protein? What is that? Protein is increased, but the cell count is normal. And if you notice the name of this condition, a very, very famous term, in fact, what is it called? Albuminocytological dissociation. Albuminocytological dissociation. Please don't forget this. This is important. It is albuminocytological dissociation. Don't forget this. This is important. Okay. Albuminocytological dissociation. This is a very famous term which is associated with Guillain-Barré syndrome. Okay, right. Please don't forget. Is that clear? Okay, fine. Now, last point will be about what is the treatment of this particular condition. Okay, see, all these group of disorders are little gray areas because we know antibodies are causing this, but exactly can we decrease that antibody by something? Nobody knows the exact answer for that, but these are all just theories which are around this particular group of conditions. And for your exam, what you should remember as a treatment of choice, it is something like this. What is it? IVIG. What is this IVIG? Intravenous immunoglobulin. Intravenous immunoglobulin. Okay, the mechanism of action is not well understood, but it is imagined like this. What is that? I told you it is the antibodies which are targeting the myelin and causing all the problems, right? Now, what happened? Intravenous immunoglobulin, as the name itself says, it is immunoglobulin, means antibody by itself. Only thing, it's a non-reactive antibody. If you give immunoglobulin to the patient, what happens? The body's immune system will get saturated with antibodies, and the body will not produce any more antibodies. So, what happens? Automatically, the harmful antibody production also will decrease. Thereby, the symptoms tend to get resolved. Are you able to understand this? That's all. Nobody knows the exact mechanism, but this is what is proposed as IVIG. IVIG is the treatment of choice in case of Guillain-Barré syndrome. Number 2 is something called plasmapheresis. Plasmapheresis. Very simple. What is that? Plasmapheresis means you are taking out the patient's blood, small amount of patient's blood you are taking out. You are removing all the antibodies from the circulation and giving it back to the patient. That's all. It is something like a way of purifying the patient's blood by removing antibodies from the patient's blood. That is called as plasmapheresis. But remember, the treatment of choice is always IVIG, which is what you need to remember very clearly about. Is that clear? Okay. So that is all about the section of Guillain-Barré syndrome, which you should know. Okay, Guillain-Barré syndrome is a very important topic. I have seen many questions, including this year. This January exam also, there was a question related to GBS. Okay. So always have a strong clinical correlation because based on that only you will be able to answer these questions. Okay, fine. Then we move on to the another condition. What is this? Another condition that is also something involving the myelin only. Okay, that is also involving the myelin, which is called as multiple sclerosis. Now, this is a condition which is autoimmune condition. Very, very important. It's an autoimmune damage to the myelin. It's a condition of autoimmune damage to the myelin. And generally, you all know autoimmune disorders are more common in which gender, males or females. Obviously, it is more common in the females. So I'm going to write it is females more than the males affected by multiple sclerosis. Females more than the males. Okay, right? And of course, autoimmune disorder means you will have autoantibodies. Do you know what are the antigens? Do you know what are the antigens against which the antibodies are produced? Okay, I will write in terms of antibodies. Okay, or okay, I'll just write in terms of antigen itself. You think like this: antibody to that antigen will be produced. Two important names should be remembered. One is called MVP. Another one is called MOGP. In India, what does this MVP stand for? MVP stands for the myelin basic protein. MVP stands for the myelin basic protein. Number 2, MOGP stands for the myelin oligodendrocyte. Very important. Oligodendrocyte. Oligodendrocyte. Glial protein. Glial cells. I think all of you know something related to the glial cells only. Glial protein. But basically, the antigen or the autoantibodies produced against these antigens. That is what I am talking about. Two important names: myelin basic protein, another one is myelin oligodendrocyte glial protein. Okay, that's what you need to remember. Okay, so whatever I have told you, these are all facts only. These are just simple facts only, which I will be discussing. Okay, which I wanted to tell you. Now I'm going to tell you about the clinical aspects of this multiple sclerosis. I told you it's an autoimmune disorder, more common in the females. Now, the disease itself is very, very bizarre. What I'm trying to say, we cannot have one feature which will be diagnostic of multiple sclerosis. Nobody can say that. A different, see, I told you, multiple sclerosis is a condition which will not have only one episode. I told you this is a condition of recurrent episodes. This is a condition of recurrent episodes. That's what I told you itself. I have told that in the beginning itself. Can you recollect? Guillain-Barré syndrome. See here, I have written here. Guillain-Barré syndrome is an acute condition. There is only one presentation. Whereas multiple sclerosis is something which is recurrent in nature. That's what you need to remember. And every time, recurrent in nature means what? Multiple attacks of multiple sclerosis will occur. Okay, right? Multiple attacks will occur. Okay. Every time when an attack of multiple sclerosis occur, the manifestation will be different. That is why, can you see what I have written here? Multiple sclerosis, the characteristic feature is multiple neurological deficits which cannot be explained by one lesion. Cannot be explained by one lesion. Meaning, think like this. It's a middle-aged female. One presentation, she had weakness of the limbs. Think like this. Few months later, she had a second attack. At the second presentation, she had optic muscle weakness or optic nerve involvement. Third time, like few more years later, she's presenting with a third attack of multiple sclerosis. At the time, her sensory functions were affected. Are you able to understand this? What I'm trying to say here is, you cannot diagnose multiple sclerosis with only one feature. That is why this is important. Multiple neurological deficits will be present. Okay. At some point of time, some features will be there, like motor features would be at one presentation, sensory features would be at the second presentation, something like multiple neurological deficits can be noted in this single patient itself. And you may be thinking, what type of condition I'm dealing with itself? That is what is the multiple sclerosis. Multiple types of neurological problems will occur. Just to put it up for the exam purposes, the most common one is sensory manifestations more than motor manifestation. Sensory more than motor manifestation. And what does the sensory manifestation look like? Abnormal sensation. For example, you touch the patient will say that I am feeling as a pain. You may have only touched the patient, but the patient would say that I am feeling it like a burning sensation, painful sensation, something like that. This is what we call it as what? Patient, you give one stimulus to the patient, but patient perceives this as a different sensation. What do we call that? It is called paresthesias. Okay, it is called as a paresthesias. That's what I'm trying to tell you. Sensory involvement is more than the motor involvement. Motor involvement, of course, is in the form of weakness only, weakness of the limbs like that. But it is the sensory involvement which is more common compared to motor involvement. And number two, which is something like a unique association. I can put it like this because not many of the neurological disorders we study like this. That is why. Any of you know one more unique association of multiple sclerosis, something related to ophthalmology. They might have told you. Whenever you have a patient who is presenting with optic neuritis, recurrent episodes of optic neuritis, one of the important differential diagnoses is multiple sclerosis. Multiple sclerosis is uniquely associated with optic neuritis. Well, you have all these problems, no, like blurring of vision, okay, optic nerve head is getting damaged, shows evidence of inflammation, all those things, optic neuritis. This is important, and I'm putting a star. Association of multiple sclerosis with optic neuritis is something which is very commonly asked in the ophthalmology side. That's what you need to know. Clear, doctors? Okay, fine. Okay. And this particular condition, I told you, multiple neurological problems are going to be affected. So what I'm trying to tell is multiple areas in the brain can be affected. And what is the best way to look at the areas affected in the brain? It is by doing an MRI. The very, very important one is T2 weighted MRI. Okay, I will take up the picture. This is how it will appear in the MRI. Can you see that? This is the MRI of the brain. And can you see what is this area which I'm highlighting now? What is this area? What is this? It is the ventricles. It is the ventricles. And surrounding the ventricle, can you see all these white areas which I'm just marking now? All these white areas. These white areas are the areas of demyelination. So please write what is the area which is, see, I've already written. T2 weighted MRI is the investigation of choice, or MRI is the investigation of choice. In MRI, what you will see is white area. White area means it is increase the signals in that area. Increase the signals in that area. Okay. And where are you getting that area? Surrounding the ventricle. It is basically periventricular white matter. Periventricular white matter. I'm not saying always periventricular white matter is affected, but the most common site for lesions to occur is always periventricular white matter, where you will see increased signals. Okay, where you will see increased signals in the form of white areas in the MRI. Yes, doctor, I'm coming to the teratophoresis part next. Okay, investigation of choice is always this particular MRI only. Okay. Again, purely for your academic purpose, what you can do is you can do something called CSF analysis. You can do the CSF analysis. I told you this is purely for means academic purpose. Nobody is going to do CSF analysis for multiple sclerosis. Only for your MCQs. I'm just trying to tell you. See, this is a condition characterized by lot of antibodies, right? Lot of antibodies means antibodies belong to which group? Proteins, right? So basically, what I'm trying to say is there will be increased proteins in the CSF. Increased proteins in the CSF. All these proteins are representing what? The autoantibodies. Do you remember the autoantibodies? I have told you what is that? Antibody against myelin basic protein. Antibody against myelin oligodendrocyte like protein. As some of you were saying very clearly, they belong to IgG type. These antibodies, they belong to IgG type. So what will happen is that if you take the CSF and analyze it, definitely protein level will be increased. Protein levels are increased due to increased levels of antibodies only. What type of antibody you get? This is what you have to remember. It is IgG type of antibody. Correct? IgG type of antibody. How do you pick up this is only IgG type of antibody? What you have to do is that in the CSF analysis, in the CSF, you have to do a test called what? How do you separate the proteins in the CSF or any fluid for that matter, even in blood also? How do you separate the proteins? You do electrophoresis. You do electrophoresis. I think all of you might have studied about electrophoresis in your biochemistry classes. It is something like a strip of paper where you give current and look for the distribution of the proteins. Now, in case of multiple sclerosis, what's happening? There's an increased levels of which protein? IgG protein. That increased IgG protein will be seen like a thick area like this. Think of this area, which is very, very thick. Thick means it means high concentration. What is this high concentration? It's all representing the IgG, which is accumulating in all these areas. Are you able to follow this? IgG, which is accumulating in all these areas. That area alone, you will see as a thick band-like area. This is what we call it as the oligoclonal bands. This is called as the oligoclonal bands. A typical MCQ question, which is almost always asked in this particular section of multiple sclerosis. So please make a note of this. Only for MCQ purposes. If you do the electrophoresis analysis of the cerebrospinal fluid, you will see the increased IgG, which are the antibodies only, getting reflected as oligoclonal bands. That's what you need to remember. But this is purely for academic purposes only. Nobody is going to do the CSF analysis for a patient with multiple sclerosis. Okay, right? Just for your MCQ purpose and teaching. Finally, what do you think will be the treatment of choice for this condition? Finally, what do you think will be the treatment of choice for this condition? The treatment of choice is nothing but, see, it is an autoimmune disorder, right? It's an autoimmune disorder. So for autoimmune disorders, what should be the treatment of choice? Autoimmune disorders, it should be steroids. It is going to be steroids. Clear? For autoimmune disorders, it is going to be steroids. I hope you're able to follow this. That's about this particular topic of multiple sclerosis. So till now, what I have told you is two important disorders involving the myelin. One was an acute condition of Guillain-Barré syndrome. Another one was about the multiple sclerosis, which is a recurrent condition. Okay, Guillain-Barré syndrome is a post-infectious condition, whereas multiple sclerosis is an autoimmune condition. Okay, Guillain-Barré syndrome, the typical presentation is ascending paralysis. It is symmetrical paralysis, whereas for multiple sclerosis, we cannot have a characteristic, clinical feature because it will be multiple neurological problems. Don't forget, generally sensory is more common compared to the motor, and a special association is for optic neuritis. Don't forget that. Okay. Now, investigation of choice for Guillain-Barré syndrome is electromyogram, whereas for multiple sclerosis, it is MRI. In both conditions, you can do CSF analysis purely for academic purpose of learning. What is the characteristic CSF analysis finding in Guillain-Barré syndrome? It is albuminocytological dissociation, whereas for multiple sclerosis, it is the presence of antibodies in the form of oligoclonal bands or IgG bands. The treatment of choice for Guillain-Barré syndrome is IVIG, whereas for multiple sclerosis, it is steroids. That's what you need to remember. This is a summary of two conditions involving the disorders of myelin. I hope you're able to follow this. Okay. All right. Now, one more thing we are going to discuss. Okay, one more thing we are going to discuss here. It will be about something called neuromuscular junction disorder. It will be something called as the neuromuscular junction disorders. Okay, right? Now, neuromuscular junction, first let us have an idea about this neuromuscular junction, and then we will discuss about the disorders of this neuromuscular junction. Okay. Yes, so let us see here. This is the neuromuscular junction which I'm drawing like this. This is the neuromuscular junction which I'm drawing like this. Okay, and this is the nerve area, and this is the muscle area. Think like this. This is the muscle area. Okay. Nerve impulses will come, will travel like this towards the nerve ending. And whenever the nerve impulses reach the nerve endings, what will happen is there is something called calcium channels. These are called as the calcium channels. Through the calcium channel, the calcium will enter inside. And do you know what will happen after this calcium enters inside the nerve ending? It will trigger the release of the substances. Think like these substances which will be released out. What are these substances? I'm just writing like this. These are the acetylcholine. They will come out of the nerve and they will act on the muscle. In the muscle, you have these. What are these? These are the, I'm just writing like these are the acetylcholine receptors. So think like this, acetylcholine is coming, it is acting on the receptors like this, it is acting on the receptor like this. What is the advantage? Muscle will get excited if this acetylcholine comes and act on the acetylcholine receptors on the muscle, and this will cause muscle contraction. This will cause muscle contraction. Are you able to understand this, doctors? Are you able to understand this? Right. And at the same time, you have to remember there is a danger in this. See, this is the neuromuscular junction area. This is the NMJ or neuromuscular junction. There is something like a danger for the acetylcholine in the neuromuscular junction. What is the danger for the acetylcholine in the neuromuscular junction? Any comments? What is the danger? Danger is there will be something like these enzymes which can degrade the acetylcholine. What is the name of this enzyme? I'm just drawing here. I'm just writing here. The name of this enzyme is, yes, ACHE. We have already discussed this concept yesterday. What is that? Acetylcholine esterase. Acetylcholine esterase. Okay. I think this is what we learn about in case of neuromuscular junction. Normal physiology, I told you. Again, going through that physiology, again, what is that? Once the nerve impulse reaches the muscle, okay, there will be influx of calcium through the calcium channels. These are the calcium channels. Okay, right? The calcium will come into the neuromuscular junction, into the nerve like this. And once the calcium comes inside the nerve, it will trigger the release of this one. What is this one which we are talking about? Acetylcholine will get released. Acetylcholine will act on the receptors in the muscle, and that will cause muscle contraction. But always remember, there is one danger to all this acetylcholine, which is in the form of acetylcholine esterase, which is present in the neuromuscular junction. That's all. Okay. So this is a normal neuromuscular junction and the physiology associated with this. Now we are going to look at two disorders somewhere related to this neuromuscular junction area. One disorder is a very famous disorder called myasthenia gravis. Repeatedly, you get questions from this. I'm not sure only I am discussing, even in your ophthalm classes, they must have discussed, because ophthalmological manifestations are very characteristic in case of myasthenia gravis. And can anybody tell me, if you have read before, I think ophthalmology is over for you, can anybody tell what is myasthenia gravis basically? I've already written myasthenia gravis is an autoimmune disorder. Any idea what is that autoimmune problem here? I'm waiting for an answer. Can anybody tell me what is the autoimmune problem here? What is the autoimmune problem? Any comment? What is the autoimmune problem? Very good, very good. That's what is the answer. Okay, it is an autoimmune disorder characterized by the body producing these antibodies. What are the antibodies? Anti-acetylcholine receptor antibodies. Okay, so think like what is going to happen? I'm saying acetylcholine receptor antibody. So I'm just taking in red color. Okay, I'm just taking the red color. These are the acetylcholine receptor, ACH receptor antibodies. Anti-acetylcholine receptor antibody. Think like this. What they will do? They will block all these receptors. Are you able to follow? They will block all the acetylcholine receptors. When they block all the acetylcholine receptors, what is the problem? Will the acetylcholine come and bind on the receptor? It will not even bind on the receptor because all these receptors will be occupied by the antibodies. So do you think muscle contraction will occur? Muscle contraction will not occur, and this will result in the weakness of the muscles. Means muscles are not able to contract. That is what I am writing. It will result in the weakness of the muscles. So let us write it up in words. Acetylcholine receptors antibody will occupy. They will occupy acetylcholine receptor. They will occupy all the acetylcholine receptors. What is the problem? If this is going to occur, they will prevent acetylcholine binding to the receptor. They will prevent acetylcholine binding to the receptor. When acetylcholine cannot bind to the receptor, it would result in weakness. I hope you're able to follow this. When acetylcholine is not able to bind to the receptor, it is going to result in weakness. Is that clear? Everybody able to follow this? Very simple, correct? Yes. I hope you're able to follow this, right? Right? Yes, that is true. That is what it is. Okay, fine. So that is what is the basic problem in case of myasthenia gravis. Okay, where patient has antibodies against the acetylcholine receptor in the muscle. That's all. Now, one association, it's not for all patients. Some patients, it is noted that they can have thymoma. Thymoma means a tumor of the thymus gland. That is what it is. Not all patients, some patients they have an association, but this has been asked in your exams already, so that's why I wanted you to know about this. Even when I tell you later about the treatment aspect, at the time also I will again come back to this association. It is associated with the thymoma. Okay, now I told you it is a muscle weakness, which is a feature of the disorder. That's something which is very easily understandable. What is the early group of muscles to be affected in this particular condition? That is why I told you it has got a lot of associations in your ophthalm classes also. I'm sure in your ophthalm classes, the faculty must have discussed about this particular association also. And if you can tell me, What is the early group of muscles to be affected? Yes, it is EOM. What is that? Extraocular muscles. Extraocular muscles, EOM, as well as LPS. What is LPS? Levator palpebrae superioris muscle. Levator palpebrae superioris muscle. Now you can ask me, what is the reason why these muscles are affected first? And if you can have a reason why these muscles are affected early in case of myasthenia gravis, why not the skeletal muscles? Why only these muscles, extraocular muscles and levator palpebrae superioris is affected? Because naturally these muscles, they have less concentration of acetylcholine receptors. Less concentration of acetylcholine receptors. What is the importance of knowing this? See, think like this. In the extraocular muscle junction, there is only 10 receptors. Whereas in skeletal muscle, you have hundreds of receptors. Think like this. In extraocular muscle region, you have only 10 receptors. Whereas in the skeletal muscle, neuromuscular junction, you have 100 of receptors. What will happen if there are 10 antibodies itself? It can easily block all the receptors in the extraocular muscle region. Whereas 10 antibodies are not sufficient to block 100 of receptors which are present in the skeletal muscles. Are you able to understand this? That is what is the meaning. There is a less concentration of acetylcholine receptor in these areas. So that is why extraocular muscles and levator palpebrae become the first muscle to get affected. Okay, so now you tell me what will be the manifestation. Very simple. If extraocular muscles are affected, what is the problem? What is the problem? Eyeball will not be able to move properly. Whenever eyeball is not able to move properly, and when a patient is looking at one particular object, will he be able to focus on that object properly? Focusing on an object requires movement of your eyeball properly or extraocular muscles properly. Your extraocular muscles are not working properly, so the focus on an object may not be proper. So what will it result in? It will not result in a clear vision. It will be resulting in something like a double vision or a diplopia. That would be the characteristic feature, correct? Diplopia. Next thing, levator palpebrae superioris is affected. What will be the manifestation? Levator. Levator means elevator. Elevator of the lid is what is levator palpebrae superioris. When that muscle becomes weak, the lids will start drooping downwards. What do you call that manifestation? Lids start drooping downwards. Ptosis. Very characteristic. Okay. So very, very important. Diplopia and ptosis. Are you able to follow this? This is the typical way by which the patient will have this finding. Okay. Look at this picture. Can you see? This is the affected side. Can you see that? The lids are actually drooping. The lids are actually drooping. Are you able to understand this? This is the manifestation of the ptosis. Now, I think some of you must have read about this. You can tell me. When do you think they will have weakness? Do you think they will have weakness throughout the day or something like morning double? Is there any morning, evening like that? Is there any difference? No, not down. No. Very good. They have more weakness in the evening. Okay. So I'm writing weakness. I write here weakness increased in the evening time compared to the morning time. Please make a note of this. And that is also the characteristic feature of this weakness. Okay, I'm writing here most important or most characteristic feature is the diurnal variation. Diurnal variation. That's what I've written. Weakness will be more in the evening compared to the morning. And whenever a patient does any exertion, like for example, the child is playing or the patient is doing a strenuous activity like exercise, something like this, after an exertion, the weakness will become worse. Okay, I'll also write the weakness will become worsened with exertion or activity. That's what I want you to remember. Okay, so this is a characteristic feature where a patient with the myasthenia gravis will have more weakness in the evening time as well as more weakness in the activity or exertion. I hope you're able to follow this. Everybody able to follow this? Okay, very good. Okay, correct. That will be more like treatment aspect of it. I will just come to that later. As of now, just remember this, that evening time or with exertion, the weakness will become very worse. That is what you need to remember. Okay, so the early group of muscle affected is extraocular muscle and the levator palpebrae is something related to the eye and the vision. Late group of muscles will be affected later. You will have involvement of the skeletal muscles also. And which group of skeletal muscles? Proximal group of skeletal muscles. Proximal skeletal muscles will be affected. Proximal group of skeletal muscles will be affected. Think like this. Example, shoulder girdle muscles. Shoulder girdle muscles. Hip muscles will be affected. So the patient will say that I am having difficulty in gripping the hands up like this when the shoulder is getting affected and all. So that will be a late manifestation. Early manifestation will always be the eye and the vision. That is what you need to remember. Clear? Okay, so that is about the characteristic features of this particular myasthenia gravis. Okay, now we move to the testing. How do you test this patient for possibility of myasthenia gravis? Okay, there are two things: screening test and diagnostic test. First, we will talk about the screening test. Any idea? The name of this test is a very famous term called tensilon testing, where we administer something called hydrophonium. Hydrophonium. Can anybody comment on what is this hydrophonium? What is this hydrophonium? Very good, Dr. Anu. Correct. Yes, tensilon test or hydrophonium test. What is hydrophonium? Hydrophonium is a short-acting acetylcholinesterase inhibitor. Please note that hydrophonium is a short-acting acetylcholinesterase inhibitor. Once you give hydrophonium, what do you think will happen? There will be improvement in the weakness. There will be improvement in the weakness. There will be improvement in the weakness. Okay, right? There will be improvement in the weakness. Okay. Why do you think there is an improvement in the weakness? So think like this. For example, this was the patient who was having the manifestation. This was the patient who was having the ptosis. After giving hydrophonium, what do you think will happen? The eyelid is elevating. Are you able to understand this? That is what we call it as a response. Okay, the improvement in the weakness is happening. So how do you think hydrophonium will cause improvement in the weakness in this particular condition? Or in other words, how do you think acetylcholinesterase inhibitor will cause improvement in the weakness? Any comment? How do you think acetylcholinesterase inhibitor will cause improvement in the weakness? Very, very simple. See here. Think like this. This is the neuromuscular junction. You don't need to draw this. Just this is the neuromuscular junction. There are 3 acetylcholine receptors in the muscle. Think like this. 2 of these acetylcholine receptors are already occupied by the antibody. Imagine you have only one receptor which is not occupied by the antibody, and that is where acetylcholine can come and act. But once acetylcholine is released into the circulation, there is a threat to the acetylcholine antibody. What is that? Acetylcholine esterase enzyme, which will inactivate this acetylcholine. Are you able to understand this? So, if I can inhibit this acetylcholine esterase from acting or from production, what will happen? The acetylcholine will act on the acetylcholine receptor for a long time without being destroyed by acetylcholine esterase. Are you able to understand this? So, when acetylcholine acts on the receptor for a long period of time, it can cause improvement in the weakness of the muscle. Are you able to understand this? That is how acetylcholine esterase inhibitors will be helpful in this particular condition. So that is why in the tensilon testing, after giving hydrophonium, there is improvement in the weakness. I hope I am able to make you remember this particular concept. Are you able to follow this, doctors? Right? Yes, good. Okay, fine. Now, this is just for a screening purpose. In the OP itself, you can do this test and can make a possible diagnosis. But what is a diagnostic test? Diagnostic test for 2 things. Most accurate, just like I told you, all neuromuscular junctions, or most accurate test will be about single fiber electromyogram. Single fiber EMG. Okay, single fiber electromyogram. And in the single fiber electromyogram, what we do is something called repetitive nerve stimulation. Repetitive nerve stimulation. Okay, repetitive nerve stimulation. Okay. What do you think will happen in repetitive nerve stimulation? Any idea? Repetitive nerve stimulation. Any idea what do you think will happen in a repetitive nerve stimulation? Okay, I'll just try to explain it to you. Just a minute. You don't need to draw this, okay? Just for your explanation, I'm just drawing it. Electromyogram is something like this, okay, right? You give an impulse. You give an impulse through the nerve. You give a nerve impulse. And once you give a nerve impulse, the muscle will start responding by contraction, right? And that contraction is what we pick up on an electromyogram. Think like this. This will be the contraction. Second impulse you give here, again, there will be one more contraction. Are you able to follow? Again, third impulse you give here, there will be one more contraction like this. It will go on like this. Are you able to follow this? So repeatedly, whenever you give a nerve impulse, what happens? Every time you will get the muscle contraction like this. But in case of MG, I'm writing like this, myasthenia gravis, when you repeatedly stimulate the muscle, what do you think will happen? I told you, exertion will worsen the weakness, right? So will you get the same response every time when you stimulate the muscle again and again? No. Every time, see, these are 3 impulses which are applied at these 3 areas. First muscle response will be okay, like this. The second response will be decreasing. Third response will be even decreasing. Fourth response will be even lesser. Fifth response will be lesser. And at one point of time, you won't even get a response. So what I'm trying to tell you, as the number of impulses goes on increasing, what is happening to the response in the muscle? It goes on decreasing. Are you able to understand this? This is what is happening in case of myasthenia gravis, because already I told you, in myasthenia gravis, any exertion or activity will worsen the weakness. That is what I told you, right? Are you able to understand this? So repetitive nerve stimulation is going to cause decremental response. This is the word which I want you to remember. It is going to result in decremental response. Is that clear? So this is something which is very, very important. Characteristic and the most accurate test is by doing electromyogram. by doing repetitive nerve stimulation, you will get a decremental response in case of myasthenia gravis. Please note this. Okay, you get a decremental response. Okay, this is the most accurate. Any other test which we can do, that is also diagnostic test only, but not very accurate, because some cases you get false negative also. That is why you can look for anti-acetylcholine receptor antibodies also. Anti-acetylcholine receptor antibody testing can also be done. Of course, that is also diagnostic only, but most accurate test, which is a commonly asked MCQ question, is single fiber electromyogram. Don't forget this. Is it clear, notice? Okay, fine. Then you take the next page. What is that? It is about the treatment. What is the treatment we can do? The treatment we can do is, you can give a long-acting acetylcholinesterase inhibitor. I have already told you acetylcholinesterase inhibitor, how they are going to work in a patient with myasthenia gravis. What they will do, they will prolong the action of acetylcholine on its receptor, thereby improving the weakness. See, for a testing purpose, you can use a short-acting acetylcholinesterase inhibitor because we want to get immediate result. But for a treatment purpose, you have to use long-acting acetylcholinesterase inhibitor because logically you want the drug effect to last for a long period of time. So that is why you are using long-acting acetylcholinesterase inhibitor. Any of you can tell me any name or example for this long-acting acetylcholinesterase inhibitor? Very good. Most of you said it. Pyridostigmine. Very correct. Pyridostigmine. This is the usual drug which we start as the initial treatment option in a patient with myasthenia gravis. Suppose the patient is not responding. Imagine to this treatment, the patient is not responding. What are the other treatment options we have? We have two options. One, we can go for the steroid treatment. Another one is that if the patient is having thymoma, I told you, there is an association with the thymic tumor. It is said that surgery, what is that surgery? The removal of the thymus can also help in the improvement of the patient's symptom. Surgery, what is the surgery? Thymectomy can be attempted. Are you able to follow this, right? So just make a note of it. Initial treatment will be long-acting acetylcholinesterase inhibitor. If the patient is not responding to that, then you can go for steroids or surgery in the form of thymectomy. Are you able to follow this, right? These are the things which you should remember regarding this myasthenia gravis. Clear on this? Fine. Okay, right. So only 3 or 4 essential points actually. Myasthenia gravis first involved the vision in the form of ptosis as well as diplopia. Second important point, weakness is worse in the evening time as well as it is worse after the exertion. Last important thing is, for the treatment purpose, you always start with long-acting acetylcholinesterase inhibitor. No response, you go for surgery or thymectomy. Dr. IcePack testing and all is now an outdated test. Nobody is doing that IcePack testing. So you don't need to remember that for your exam purposes. Okay, of course, as you are saying, something like IcePack can improve the symptoms and all, that's all okay. But nowadays, nobody is using that test. It is not asked in your exams also. Okay, right? That's more like an outdated test. Okay, fine. So that is all about the myasthenia gravis, which you should remember. Just a quick note about one more condition actually called as Lambert-Eaton syndrome. It is something related and something different from myasthenia gravis. What is that? In Lambert-Eaton syndrome, the problem is something like this. Okay. What are these channels which I was talking about? Through which calcium enters inside? I told you. Okay, these are called as, please remember, these are called as a voltage gated calcium channels. Okay, right? Now I told you, these only when the calcium enters, it will trigger the release of acetylcholine. I told you that, right? It will trigger the release of acetylcholine from the nerve endings. I told you this. Okay. So think like this. In Lambert-Eaton syndrome, what happens is that there will be autoantibodies. It is also autoantibodies only. The antibodies, or in the simply right here, antibodies will be against the calcium channels. Antibody will be present against the calcium channels. So what happens? You think like this. There will be antibodies which will inhibit all these calcium channels. Without, they will not function. That is what I'm trying to tell you. So when calcium is not coming into the muscle, what will not be released from the, when calcium is not coming into the nerve, what will not be released from the nerve? Acetylcholine will not be released from the nerve. Acetylcholine will not have any action on the muscle, and thereby it will result in weakness of the muscles. Are you able to follow this? So here the problem is antibodies against the calcium channels. Okay, right? So answer one more thing. What is this area? It's the neuromuscular junction area. Any other name for this neuromuscular junction area? Synapse. It is also called as a synapse. So can I say this Lambert-Eaton syndrome is a presynaptic disorder? It is a presynaptic disorder. Very simple, correct? Synapse is the neuromuscular junction. It is before the neuromuscular junction. So it's called presynaptic disorder. That is the point. Whereas myasthenia gravis, where is the problem? In myasthenia gravis, the problem was after the synapse. In the muscle, there were receptors, right? What is that? Acetylcholine receptors which are blocked by the antibodies. So myasthenia gravis is a post-synaptic disorder, whereas Lambert-Eaton syndrome is a pre-synaptic disorder. Okay, right? This is something which is different from each other. There are also other differences which I want you to quickly remember. First, let us just fill out all these things. What is that? Myasthenia gravis. What is the type of antibodies you get? Anti-acetylcholine receptor antibody. In Lambert-Eaton syndrome, the antibodies are against voltage-gated calcium channels. Okay, antibodies are against voltage-gated calcium channels. Correct. Antibodies against voltage-gated calcium channels. What is the association for myasthenia gravis? I told you which tumor? It is thymoma. That's a famous question I told you. What about Lambert-Eaton syndrome? It's a tumor of the lungs. Any idea what is that? Small cell lung cancer. Small cell lung cancer. And this is one of the examples of paraneoplastic syndromes. You will learn in your pathology classes in detail about paraneoplastic syndromes. So this is one example of a paraneoplastic syndrome, where we cannot explain directly due to the lung cancer, but something which is associated with the lung cancer, and it is called as a paraneoplastic syndrome. Okay, have you heard about the term paraneoplastic syndrome? Yes, correct. Paraneoplastic syndrome. Now, what will be the effect of exercise in a case of myasthenia gravis? It will make the weakness to be worse, whereas in case of Lambert-Eaton syndrome, exercise will improve the weakness. You don't need to go into the reasons at all. It's all very complicated. You don't need to go into the reasons. Just remember as a difference. In myasthenia gravis, it becomes worse with exercise. In Lambert-Eaton syndrome, it will improve with exercise. Similarly, repetitive nerve stimulation. What will be the response? Incremental or decremental? Yes, I told you it's a decremental response. Whereas Lambert-Eaton syndrome is the opposite. What is that? It will show an incremental response. It will show incremental response. I hope you're able to follow this. Everyone able to follow this, right? So those are the differences between myasthenia gravis and Lambert-Eaton syndrome, which you should be knowing about very correctly. Is that clear? Everyone able to follow this? Okay, right. So that's about two examples of disorders related to the neuromuscular junction area. One was pre-synaptic, another one was post-synaptic. Is that clear? Fine. Okay, so that would be for this particular session, which I have told you about some of the neuromuscular disorders. I started the class with some disorders involving the myelin. Then I told you about some disorders involving the neuromuscular junction. Okay, right? Next section, after the break only, we are going to discuss about something related to spinal cord hemisection. See, this is a very, very important topic. And tell me one thing, if this has been discussed in your anatomy classes, I think anatomy class is over. Have they discussed about all these spinothalamic tract, dorsal column pathways in the spinal cord and all? Have they discussed about this spinothalamic tract, dorsal column pathways in the spinal cord region and all? Have they discussed? Okay. What is that? Incremental and decremental. No. It is something equivalent to, what is that? Something equal. See, it is something equivalent to how to say, repetitive nerve stimulation. I told you, the weakness is going to worse, so there is a decremental response. In case of Lambert-Eaton syndrome, the weakness will improve, or that is what is called incremental response. That's all. So when you stimulate the nerve continuously, it is going to be showing an incremental response. That's all. Okay, fine. So I see that most of you are saying that it has been discussed already in anatomy. So all I want you to do in this break time is just go through this, just go through that particular part of anatomy. Read about the nerve endings and all, read about the spinothalamic tract, read about the dorsal column pathway in the region of the spinal cord, and come prepared for a discussion after a break. The reason for giving the break is for you to know, read once about this particular pathways. Okay, that is why. Because I know, like I can continue the class and finish it off quickly also, but that is not the aim. I want you to know, read this from your anatomy notes once. You can even take extra 5 minutes also, not a problem. And then after the break, if I start a discussion, I hope you will be able to answer about this particular thing. Okay, fine. So please check it out. Please read it once. You can even take extra 5 minutes also. We'll go for the break now. After the break, we will continue the discussion, starting with the hemisection of spinal cord. Okay, right. Around I will do now 11:25. Around 11:45, 11:50 like that, I will start the class. Okay, is that fine? Right. And also, if time is permitting, you can see the MCQs, neurology MCQs, which I have given to you. And once we finish the neurology part, I will go through all the MCQs. I will discuss all the neurology MCQs. Fine? Okay. Yeah, so we'll start now. Yes. So we will get started. Sorry for that. There were some power fluctuations in my place. It can happen again also. But it's okay. We'll just continue with the discussion. Yes, we were discussing. We are going to discuss about this particular condition called hemisection of the spinal cord. What you go by the name of Sequard syndrome, Brown-Sequard syndrome. Any of you or have you seen in your anatomy notes regarding the Sequard syndrome? Yes. Have you seen about the Brown-Sequard syndrome? Just a minute, 1 minute. Okay. Fine. Okay, so let's continue. Right. So yes, right. Very good. Some of you have already seen it. So that is good. See, it is something related to the spinal cord hemisection. Hemisection means what is the meaning? Part of the spinal cord is being transected like this. It is being cut like this. It usually occurs in the setting of something like a accident. Okay, during the time of accidents, this can happen, or think something like a rivalry where the patient is being stabbed by another person with a knife like that in his backside. Okay, and a very famous thing which you might be knowing about is in the movie Mark, this Bahubali and all, where the person is getting stabbed from the back and all, right? So something like that particular situations when the spinal cord is sort of transected, okay, you can have something called Brown-Sequard syndrome. Okay, so what I'm trying to say is it is something like this: one half of the spinal cord is completely being cut off. Think like this: one area or the one half is completely being cut off. That is what is the hemisection of the spinal cord. That is what is the hemisection of the spinal cord. Okay, right. And this condition is characterized by more of sensory disturbances rather than motor disturbances. It's more of sensory compared to motor. Most of the features which you will see are related to the sensory manifestations only. Okay, right. So just try to tell me about the arrangement of the tracks in the spinal cord. Arrangement of the tracks in the spinal cord. Okay, you may notice some lag during my discussion, but this is a part of this. There is a issue with the signal going on here, so that is why there is a little bit of disturbances. But please try to get together with this. We need to finish off this particular system. Okay, right. So suppose I draw the spinal cord like this, the same picture only which I have put up like this. The same spinal cord only like this. Okay, right. Right. So yes. Okay, so this is what I'm drawing. Okay, fine. Now tell me, what are the tracks in the spinal cord? Okay, we have the ascending column, we have the descending tracks also, ascending tracks as well as the descending tract. The descending tract is something which runs like this. What is the descending tract which I'm talking about? What is the descending tract? It's already marked. What is that? Corticospinal tract. Corticospinal tract. It is a corticospinal tract. Now, think of this as the left side. Okay, think of this as the left side. Just imagine this as the left side. Okay. Now, this corticospinal tract is carrying sensations for the left side of the body, not sensation, I'm sorry. It is carrying the motor supply to the same side of the body or to the opposite side. I'm talking about corticospinal tract on the left side. Is it carrying the nerve supply to the left side of the body or to the right side of the body? Yes. Comment on this corticospinal tract. It is carrying the nerve supply to the same side or the opposite side. It is to the same side only. It is to the same side only. Doctors, don't get confused. Corticospinal tract is already crossed at the level of, it is already crossed at the level of what? It is already crossed at the level of medulla. Okay. So whatever is coming on the left side of the spinal cord is going to supply to the left side of the body only. Are you able to understand this? Don't get confused with yesterday's discussion. Yesterday I told you the fibers which originate from the right side of the motor cortex will supply the left side of the body. That is what I told you yesterday, because they are not crossed fibers. They cross only at the level of medulla. But now this particular area spinal cord, we are talking after the medulla only. After the medulla, the fibers are already crossed. So the corticospinal tract, which is on the left side of the spinal cord, is going to supply the muscles on the left side of the body only. So this is same side or ipsilateral. I hope this is clear. This is clear. Are you able to follow this? Okay, so this is on the same side. Okay, fine. Then this is the descending tract. Now tell me, what are the ascending tracts? What are the ascending tracts? One ascending tract will be something like this. This ascending tract. Any comment about this ascending tract? There are two ascending tracts actually. One is the spinothalamic tract, another one is the dorsal column pathway. So something like this. This tract is ascending up like this. Imagine. this tract is ascending up like this. Okay, it is on the dorsal side only, but I'm just saying that it is something which goes through the spinal cord and then goes above like this. What is this ascending tract which carries the sensation from the same side of the body? What is that? Ascending tract which carries the sensation to the same side from the same side of the body. This is the dorsal column pathway. Dorsal column. If it is left side, it is carrying the sensation from the left side of the body only. This is ipsilateral. Okay. Then what is the another tract? What is the another ascending tract which is going like this? It is like this. Something like this. It is also going above like this. What I'm trying to tell you, it is something which comes from the opposite side, crosses at the level of the spinal cord, and then goes above like this. So that means this tract, if I'm saying on the left side, it is carrying the sensation from the opposite side of the body. What is the tract? It is the spinothalamic tract. It is the spinothalamic tract. Correct? It is the spinothalamic tract. I hope you can follow what I'm trying to draw here. Okay, right? It is a okay, anterior and lateral, but just remember lateral spinothalamic tract. Are you able to follow this, right? Spinothalamic tract. Okay, fine. So it is carrying the sensation from the contralateral side. Okay, it is carrying the sensation from the contralateral side. Carrying the sensation from the contralateral side. Are you able to follow this? Okay, fine. So I hope everything is clear till this point of time regarding the ascending tract and descending tract distribution in the spinal cord region. It is not an exact picture, but just for your understanding only, I have put it up like this. I hope you're able to follow this. Everyone able to follow this? Okay, right. So now let us imagine that one half of the spinal cord is getting cut, or as I have put up in the main picture, this part of the spinal cord is getting cut or becoming transected. Think like this. This part of the spinal cord is becoming cut or getting transected like this. Okay, it is getting transected. So now, what do you think? You will have a problem. You will have some features on the same side of the body which are getting affected. Some features on the opposite side of the body which is getting affected. So ipsilaterally, what are the problems you are getting? See, all the problems which I'm going to discuss are something which are occurring below the level of lesion. Below the level of lesion. Below the level of lesion. Please remember this. When you study your textbooks and all, there will be something like this given at the level of lesion, below the level of lesion and all. Don't get confused so much, because at your exam level, at the screening level, what they're going to ask is what are the manifestations due to this heavy section of the spinal cord below the level of lesion. That is what they're asking in your exam, and that's what you need to follow also. Okay. Anybody wants to comment ipsilaterally? What are the things which are getting affected? Yes, ipsilaterally you have, yes, what is that? Spinothalamic tract or dorsal column sensation, which is getting affected. Dorsal column sensations are getting affected. There is loss of dorsal column sensations, correct? Or posterior column sensation. Ipsilateral loss of dorsal column sensations. What are the dorsal column sensations? Dorsal column sensations are the STD itself, I told you. Joint position or proprioception. Vibration getting affected. What is stereognosis? Stereognosis. So all these are getting affected whenever there is loss of dorsal column sensation. Clear? All these are getting affected. Loss of dorsal column sensation. Okay? Clear? Okay. Then ipsilaterally, what is the other tract which is getting affected? I told you, corticospinal tract is also getting affected, correct? Corticospinal tract is carrying sensation to the same side of the body is also getting affected. So what you will have? You will have weakness. You will have weakness of the limbs on the affected side below the level of lesion. What type of weakness you will get? UMN type of weakness or element type of weakness? UMN type of weakness or element type of weakness? Please remember, we are only talking about the corticospinal tract. Corticospinal tract is UMN or element. Simple. It is UMN. So you will have UMN weakness, upper motor neuron weakness, which is characterized by spasticity on the ipsilateral side. Okay, UMN weakness on the ipsilateral side. Okay, but the corticospinal tract is UMN. From the anterior horn cell and the nerve below only is the element. We are talking about corticospinal tract. Corticospinal tract will be about UMN weakness. That's what you need to remember. Okay, fine. So please remember this. Below the level of lesion, you have UMN weakness as well as loss of dorsal column sensation. And on the contralateral side, what type of problem you will have? You will have loss of sensations on the spinothalamic tract. You will have loss of spinothalamic tract sensation. Spinothalamic tract sensation. The main sensation would include the pain and the temperature. This would include the pain and the temperature. This would include the pain and the temperature. Are you able to follow this? This would include the pain and the temperature. Is that clear? Okay. So this is what you need to know as Brown-Sequard syndrome. Okay. This is what you need to remember as the Brown-Sequard syndrome. I hope you are able to follow this. Clear, everyone? Okay. So please remember, for your exam levels, whenever they ask you about Brown Sequard syndrome, it is always related to features below the level of lesion. One is ipsilateral, another one is contralateral. Ipsilateral side, you will have loss of dorsal column sensation as well as weakness of the affected limbs on the same side. And contralaterally, you will have loss of pain and temperature on the opposite side due to spinothalamic tract sensation getting affected. Let this be very, very clear. This is a very important question often asked in your exams, and I see students getting it wrongly by confusing with many sources. Okay, that is what I'm telling. In some of your sources, they would have given something like features at the level of lesion, like that they would have mentioned. That is what would have caused confusion when you read it. But that type of reading and all is not expected at your exam level. It is more for DPG levels where you need to know about it. For your level, it is only below the level of lesion. I hope till this point it is clear. Okay, fine. Now let us look at the next one, which is like a short scenario I have put up, something like this. What is it? You have a 45-year-old male who is brought to the emergency department with 1 to 2 days of fever, headache, nausea, and vomiting. 1 to 2 days of fever, headache, nausea, and vomiting. On physical examination, he is found to have neck stiffness as well as photophobia. What is the diagnosis? See, whenever you have fever, always you will think about infection. This I think all of you should be knowing. Always think about infection. And then you have headache, nausea, and vomiting. Okay, these may be indicating something, or this may be some associated finding also. Even a person who's having fever can have headache also as a part of fever itself. He can have vomiting also. We cannot say anything very specifically here. But look at the next line of the question. On physical examination, he is found to have neck stiffness, something which is very, very characteristic, something which is very characteristic. Photophobia means fear of light. Okay, that can be seen in many conditions. But neck stiffness is something like a very important clue. What is that? This neck stiffness is one of the signs of meningeal irritation. It is one of the signs of meningeal irritation. It is one of the signs of meningeal irritation, correct? This is one of the signs of meningeal irritation. So whenever you have a patient who's having fever, along with the sign of meningeal irritation, what is a likely possibility? The name itself is already there. It is in the form of meningitis. It is in the form of meningitis, correct? It's in the form of meningitis, okay, right? Okay, this is what you need to remember, because in your exams, an important clue to think about meningitis will be about signs of meningeal irritation. This, I think, most of you are able to get it correctly. Just quickly, can any of you tell what are the other signs of meningeal irritation? What are the other signs? What are the other signs of meningeal irritation? Other signs of meningeal irritation, anybody? Just type in your answers. I'll just take a picture, a small picture to demonstrate about this. Just a minute. Okay, I'm just taking up the pictures. Just a minute. Okay. So you can see that here, right? So this is the picture which I want you to take a note of. Okay, I see many of your answers are very clearly being said. Yes, of course. The other two important things are Kernig sign and Brudzinski sign. First of all, let me just try to explain this. First of all, I told you it is meningitis. Meningitis means inflammation of the meninges. Meninges are something which are not only in the brain, right? Meninges are something which are extending in the spinal cord region also. Think about the cervical part of the spinal cord in the neck region. There are also meninges is there. When meninges are becoming inflamed, they will cause pain in that region. That is why the patient complains of neck stiffness. Any other name for this neck stiffness? Any other name for this neck stiffness? It is also called as one more name. You can write there itself. It's also called nuchal. Nuchal is also the meaning for neck. Stiffness is also called rigidity, neck rigidity or nuchal rigidity. Okay, I hope you can understand this. It is simply because the patient has pain in the neck due to meninges which are involved in which are present in the neck cervical region. That's all. Okay, right. So that's why they can have neck stiffness. The other two signs is what is these two pictures. I will share with you the same pictures only. You can see here in this particular picture. Yes. Just a minute. Is there any lag in my presentation? Is there any lag? Is there any lag you are noticing? Like change in the screens and all, is it causing any lag? No, then it is fine. Okay, right. So see here, this sign I will just put it up first. Thank you. Okay, I'll just put it up. Brudzinski sign. It is a Brudzinski sign. What is the meaning of Brudzinski sign? Whenever you flex the neck of the patient like this, something flexing the neck like this, what is happening? The hip and the knee is also involuntarily flexing. It is very simple. Whenever you are flexing the neck, you are flexing the or you are causing irritation in this part of the meninges. Okay, and when it is causing irritation, it will cause involuntary flexion of the hip and knee again due to irritation of the meninges only. This is called as a Brudzinski sign. What is the third one? The third one is called the Koenig sign. To demonstrate the Koenig sign, what you should do, you should keep the patient's hip in a flexed position like this. You should keep it in a flexed position. And slowly, what you have to do is you have to extend the knee. That means straighten the knee up like this. You have to straighten the knee up like this. And whenever you are straightening the knee up like this, what is happening? You are stretching the meninges. Already the meninges are inflamed as a part of meningitis. And when you stretch the meninges further, the patient will complain of pain in the back area. The back area, patient will complain of pain. What is this called? This is called Koenig sign. So three important signs which you should remember. One, of course, we have already given the question. One is the neck stiffness. Number two is the Brudzinski sign. And number three is the Koenig sign. All these three signs are what we call as the signs of meningeal irritation. And whenever you have a patient with fever and any of the signs of meningeal irritation, your diagnosis is going to be meningitis. Okay, your diagnosis is going to be meningitis. I hope all of you are able to follow this, fine. That is the next topic which we are going to discuss about, which will be about meningitis. Okay. Now, turn the pages. In your next page, what I have given is two conditions. One is meningitis, another one is encephalitis. See, many times, this is like something which occurs together. Meningitis means inflammation of the meninges only. Encephalitis means what? Encephal means something related to brain. Encephal means something related to the brain. So you think like this, inflammation of the brain also. Okay, inflammation of the brain. So why I want you to know about these terms is because sometimes it can be confusing. Even though broadly if we say both meningitis, encephalitis like that we say, and there is a term also called meningoencephalitis also, where both is getting affected. But just strictly for exam purposes, you should know the differences. First thing I will tell you is meningitis is usually caused by bacteria more than virus. Bacteria more than the virus. Whereas encephalitis is usually by a virus. Encephalitis is usually by the virus. That is what I want you to remember. Okay, where only brain is affected without meningitis. However, many viruses usually cause a combined picture also called as meningoencephalitis. Meningoencephalitis, combined picture. So what I'm trying to tell you is don't get too much confused. Okay, I will tell you the differences, but sometimes question can be asking about the differences between the two conditions also. That is why I want you to know about it. And also keep in mind there is a possibility called meningoencephalitis where both the features can be present. That's what I'm trying to tell you. The usual case for your exam is usually going to be about meningitis only, which is commonly caused by bacteria. Okay, right? So if you look at the differences between the two conditions, the first three features, what are the first three features? Fever, headache, and seizures can be present in both meningitis as well as in encephalitis. I'm going to put plus. These are common features. Fever, headache, seizures. Everything can be present in both meningitis as well as encephalitis. But only thing I want you to remember is in meningitis, you tend to get GTCS. What is GTCS? Generalized clonic seizure, because every part of the brain tends to get inflamed there. Okay, because meningitis is there everywhere surrounding the brain, right? Everywhere surrounding the brain. So it causes more of a generalized seizure. This I think all of you can understand. Whereas encephalitis, usually one part of the brain is affected. Things like temporal part is affected, parietal lobe is affected, frontal lobe is affected. So what type of seizure you get in case of encephalitis? You get focal seizure because only one part of the brain is affected. That may be one difference, which I want you to remember. Then cortical lobe involvement will not be a feature of meningitis because meningitis is something surrounding the brain, not inside the brain. So cortical involvement as such will not be present. Cortical means I'm talking about cortical lobe involvement, like one particular lobe affected. It is not a feature of meningitis. In fact, that is an important feature of encephalitis. For example, you think like this: temporal lobe is affected or frontal lobe is affected. Dominant part, there is a left-sided temporal lobe or left-sided frontal lobe is affected. What type of manifestation you can get as a specific feature? Aphasias can be present. Able to follow this? Aphasia tells you it is a lobe which is affected, cortical lobe which is affected, which is a feature of encephalitis and not meningitis. Do you understand this, right? Signs of meningeal irritation, very obvious question, where it will be present. In meningitis only it is present. Signs of meningeal irritation are absent in case of encephalitis. Okay, right. Now, CSF analysis definitely will be abnormal. In case of meningitis. In fact, the best investigation which we have to do to diagnose a case of meningitis is to do CSF analysis, which I think all of you should be knowing about. Whereas for encephalitis, It is only brain involvement. So you may not get findings in the CSF analysis because CSF is something related to subarachnoid space, which is a part of meninges only. So you may not get any findings. But you understand this. So now a question can come to your mind. In case of encephalitis, to know it is encephalitis or not, I want to see the brain tissue itself. So what do you think is the investigation I will do in case of encephalitis? That's the question. What is the investigation I will do in case of encephalitis? I want to know which part of the brain is affected. Yes? Very good. Biopsy, brain biopsy will be a little difficult to do, doctor, but we can see which part of the brain is affected by doing one investigation. What is that? MRI. Okay, MRI will be the investigation to find out brain involvement with the help of MRI. Are you able to understand this? Right? So if I suspect meningitis, I have to do CSF analysis. If I suspect encephalitis, I have to do MRI to know which part of the brain is actually affected. Is that clear? So these are all more like theoretical differences because I am trying to tell you there can be a possibility called meningoencephalitis also, where you can get a combined picture also. Okay. So just for your clinical distinction in your exams, if there are some questions asking as a difference between the two conditions, you can utilize this particular table. That's all. Now, next we are going to discuss about meningitis only. We are going to discuss about meningitis only, because that would be the topic for your exams. Okay, right? So meningitis, I told you, it is more commonly caused by bacteria only. Okay, can we tell which is the overall most common? Which is the overall most common bacteria? Overall most common bacteria associated with meningitis. Overall most common bacteria associated with meningitis. Streptococcus pneumoniae. Streptococcus pneumoniae. Overall most common bacteria, it is Streptococcus pneumoniae. Okay, overall most common is Streptococcus pneumoniae. Overall most common bacteria is Streptococcus pneumoniae. Okay, there are so many other bacteria like Neisseria meningitidis, H. influenza, so many bacteria are there, but overall most common is always Streptococcus pneumoniae. Okay, now virus, if you talk about, the most common virus will be enterovirus. The most common virus would be enterovirus. Okay, right? Worldwide, everywhere it is enterovirus only. But I want you to remember that in children, it's a slightly different virus. Maybe in your pediatric session, they would have told you. In children, what is the most common virus? In India, we are talking about. In India, most common virus. It's a virus which is spread with the help of mosquitoes. Culex mosquitoes is the clue. Culex mosquitoes spreads that particular virus. JE, what is that? Japanese encephalitis. It is Japanese encephalitis. In children, the most common virus associated with encephalitis is, or meningoencephalitis is Japanese encephalitis virus. But overall, in adults worldwide, most common cause will be enterovirus. Okay. Now, there's one more thing which I want you to remember. Some of you were saying that. What is that? The question should come specifically like this. What is it? Which is the most common sporadic viral encephalitis? Most common sporadic viral infection. This is something important. The key word here is sporadic. Sporadic means not every time it is going to occur. Once in a while, condition will occur. The key word here is sporadic viral encephalitis. If you know what is that virus, it is HSV1. What is that? It is herpes. It is herpes simplex virus 1 encephalitis. It is herpes simplex virus 1 encephalitis. HSV1 encephalitis. Okay, HSV1 encephalitis. Can anybody tell me if herpes simplex is going to occur? Okay, it usually cause encephalitis. Which part of the brain is characteristically affected by herpes simplex virus? Any of you know that? Which part of the brain is characteristically affected by herpes simplex virus? It is temporal lobe of the brain. This is a very, very important question. Even in your microbiology classes, they tell you that this is an important question. So please mark it there. Okay. HSV1 encephalitis characteristically affects the temporal lobe. Okay. Please don't forget this. Okay. Of course, tuberculosis, we all know it is only Mycobacterium tuberculosis and Bacterium T. That's all. Okay. So just remember, generally it is caused by the bacteria. And in the viruses, there are some special questions which I have put it up for your reference. Okay. Now, one special thing which I want you to remember is like this. What is that? Most common cause of meningitis in a HIV infected patient. HIV infected patient. It's a very special scenario because HIV is a condition of immunodeficiency. Anybody wants to comment on this? What is that? In HIV infected patients. Okay, do you remember when I was talking about pneumonia? I told you this. HIV infected patient pneumonia occurs. That's a special group. I told you, Mycobacterium tuberculosis, Mycobacterium aeruginosa. Then we talked about this pneumocystis and all. Can we tell me for meningitis in HIV patient? Very good. It is cryptococcosis or cryptococci. Cryptococcal infections. Very, very important point. Very, very important. And cryptococcal infections are common with the CD4 count of less than how much? Any comment? CD4 count of less than how much? Where usually cryptococci can occur as an infection, opportunistic infection. Very good. Most of you got the correct cryptococcus neoformans only, but less than how much? Less than 100. This is according to the textbooks. It is less than 100, not 200 doctors. where it has been said like 200. My reference is from the medicine textbooks only, where they are clearly mentioning CD4 count less than 100. I'm not sure it has been taught somewhere else differently, because many answers I see it is 200 micro. Okay, doctors, I will just try to put up a reference, okay, because this can be something which is controversial. So what I will do is I'll take a screenshot from a book and I will put it up for a reference, okay, right? Okay, according to medicine textbooks, it is more common with a CD4 count of less than 100. I will also go through the micro text, and whichever is the best possible answer, I will tell it as the final one. Maybe after the break, I will put it up. Okay, fine. As of now, you can write CD4 count less than 100. Okay, fine. Now, for all type of meningitis, you should know that it is only CSF analysis, which will be the investigation of choice. And this is something which I think even in your micro classes, they must have told you. CSF analysis findings in a patient with meningitis, okay, for bacteria, viral, and TB. Everywhere, pediatrics, it is the same, microbiology, it is the same, medicine also, it is the same. You will learn like this only, right? It should be known by heart, because many questions, even the recent pattern questions, they will give you the CSF analysis finding, and they will ask you what type of infection is possible. Like that, they can ask you the question, okay, right? Yes. CSF pressure I have written, normally it's 50 to 80, 180 millimeters of water. What do you think will happen in all type of meningitis? Very simple question. All type of meningitis, the CSF pressure is increased. The CSF pressure is increased, correct? Because meningitis, itis means inflammation. Due to inflammation, the pressure increases. This I think all of you should be knowing about. What is the normal appearance of CSF? It is like a water which is clear. What happens in bacterial meningitis? It becomes more whitish. What do you call that whitish appearance? Turbid appearance. Or we also call it as a cloudy appearance. It's more like whitish appearance, and that whitishness is due to pus which is present. And this whitishness is due to the pus which is present. Okay, fine. Viral meningitis. Viral meningitis. What is the appearance? It's a clear appearance. Viral meningitis, it is a clear appearance. That's what you have to remember. Tuberculosis again is a battle infection. So again, it will be turbid in appearance only. It will be turbid in appearance only. Okay. And in tuberculosis, there's a very special finding, which I'm sure in your micro classes you have learned, that if you take the CSF in a test tube, okay, and make it to stand like this, after some time, what you will see is something like clots like this, which are formed in the CSF. A lot of clots are present in the CSF. Any idea what is the name of this appearance? What is the name of this appearance? A lot of clot is present inside the CSF. It is called cobweb appearance. It is called as a cobweb appearance. Okay, I will provide you the reference. I will provide you the reason little later, but as of now, write the appearance name. It's called cobweb appearance. Okay, please make a note of this. It's called cobweb appearance. Okay. Normally, CSF doesn't have many cells. It is only less than 5 cells, which are mainly lymphocytes, which are present. And in all type of meningitis, as a part of inflammation itself, the cells will be increased. That's what all of you know about. As a part of inflammation, the cells will be increased. Okay, fine. What type of cells will increase? Bacterial meningitis, it will be neutrophils, which will be increased. Neutrophils, which will be increased. Viral meningitis, it is the lymphocytes, which are increased. TB is also lymphocyte mediated disease, so lymphocyte count will be increased. That's what you need to remember. Okay, lymphocyte count will be increased. Okay, fine. Then normal protein in the CSF. Okay, normal protein in the CSF is 20 to 45 milligram per deciliter. Normal amount of protein in CSF is 20 to 45 milligram per deciliter. Bacterial meningitis, the CSF protein level will increase, because very simple reason. Bacterial proteins also will be present in the CSF, which will be counted as a protein count. So that is why more bacteria means more protein level in the CSF also. That is why CSF protein level is increased. That's what I was telling you. Okay, fine. Then virus. Virus will not cause any increase in the protein. It is usually normal. But I want you to remember one thing. It may be slightly elevated. It can be slightly elevated in Japanese encephalitis as well as HSV infection. This is given in all your standard textbooks. Generally, if they ask you viral encephalitis, protein count is normal only, but may be slightly increased in case of JE or HSV encephalitis. Please keep this in mind. Okay. Fine. Last one. What about protein count in TB? I am going to put 3 arrows for this, because it's a very high protein count. Generally, remember, tuberculosis is associated with very high protein production due to very intense inflammation. That is why the levels are very high. Okay. And one of the protein which is elevated is fibrinogen. Please remember, one of the protein which is elevated is fibrinogen. I think all of you know, fibrinogen, when it is produced, after some time, it's converted to fibrin. So what I'm saying, there will be increased fibrin also which is present. And this increased fibrin is what is going to result in the clot formation. Increased fibrin is what is going to result in the clot formation. Are you able to understand this? Increased fibrin is what is going to result in clot formation. Is that clear? Okay, fine. This is the reason why there is a cobweb or a clot formation in case of TB meningitis. Just keep in mind, that's enough. This will be about proteins. Next, we move on to the sugars. Okay, sugars. Normal level of sugar is 40 to 70 milligram per deciliter. What will happen in bacteria? Please write in the next page. Bacterial, viral, and tuberculosis. Yes. What will happen in case of bacterial meningitis? Right? Bacteria will utilize the sugar. Bacteria will utilize the sugar for its own metabolism. So the level would be decreased. Bacteria will utilize the sugar for its own metabolism. So the level will be decreased. And is there any name for this low bacterial sugar? Is there any name for this low bacterial sugar? It is hypo. Just a minute, 1 minute. Okay, so what is happening? Low glucose in the CSF is present. So what do you call this? It is called hypoglycorrhea. Please make a note of this. This exact wording had come in your exam. Okay, it is a name for hypoglycorrhea. Okay, so simple reason, bacteria will utilize the sugar for its own metabolism. Thereby, it results in hypoglycorrhea. That's all. Okay, virus will not utilize the sugar, so the levels of sugar in the CSF will be normal. TBR, of course, is a bacteria which will again utilize the sugar, so low glucose or hypoglycorrhea will be present. Are you able to understand this? Okay, fine. Now, last one is not something which is usually done. Actually, we don't calculate it. But one of the exams, it is not a very new question, little old question, where they asked about CSF and serum glucose. Normally, if you compare the CSF and serum glucose, it is something like 60%. What is the meaning? Suppose if the serum glucose is 100, you think like this. CSF glucose will be 60. That is what is the meaning. When we express it as a decimal, it is 0.6. That's what I'm trying to tell you. Normally, it is 60% of serum glucose which is present in the CSF. In bacterial meningitis, what is happening? The level of glucose in the CSF is decreasing. So what do you think will happen to this number 0.6? Will it be normal or increased? Obviously, CSF glucose decreased means in bacterial meningitis also, the number also will be decreased. So it will be low. Low, you want to remember it with a number. It is less than 0.4. Please remember. The same will apply for TB also, because in TB also the CSF glucose level is decreased. It will be less than 0.4. Whereas in virus, it is not going to be affected. It will be the normal one. What is that normal? 0.6 only. Are you able to understand this, right? So just make a note of it. This is something like one of the little old questions only, but still I feel possibility of being repeated because in almost every exam in FMG, I see one question from the section of CSF analysis and what type of meningitis it is. So that is why I want you to make a note of it. That's enough. That is enough. Okay. All right. Okay. So that is about the TB meningitis, which I want. Differences between bacterial, viral, and TB meningitis according to the CSF analysis. You have to know about this. Okay. Again, telling you and again putting a lot of stars here because this is something which can be very frequently asked in the exam. See, this is something which is CSF analysis. You have to do the other testings also. You have to do the other testings also. For example, bacteria. For example, bacteria. What test we have to do? We have to do a gram stain. We have to do a gram stain. We have to do the bacterial culture also. I hope you can follow this. Okay, we have to do the bacterial culture and the gram stain. What about virus? Can we do for virus? Can we do for the virus about? Can we do any culture testing for the virus and all? No, not required. For virus, what you have to do is we have to look for the viral antigen. Any idea what is the test for viral antigen? PCR testing. It is PCR testing. That is what we have to do. Okay. Viral load, okay, but PCR test, that would be a good enough test. Okay, it's an easy test also to do. So PCR testing can be done. For tuberculosis, any of you know what is the test we do? CBNAT. This I think all of you must have heard about this. What is that? Cartridge-based nucleic acid amplification testing, which I'm sure most of you must have heard about in your micro classes itself, right? CBNAT testing. Okay, right? And think about HIV positive patient who had cryptococci infection. Yes. Any comment? Cryptococcal infection. What is the special test we do in the CSF? This I think all of you should be able to answer. Very good. What is that? India ink test. Very correct. India ink test. It would be given in a question, something like this. You have a HIV positive patient who had meningitis, and as a part of investigation, CSF analysis was done, and India ink testing is performed. What what infection you are dealing with? Like that, they can ask you the question. Okay, right? India ink preparation has been something like that, black and white color. No, you must have seen in your micro classes. You can also do the cryptococcal antigen testing, but the initial testing, which is usually given as a clue in your exam, is the cryptococcal. For cryptococcal is the India ink testing. That's all. Okay. So, what are the management options? Okay. Okay, for a typical bacterial infection, please remember, for a typical bacterial infection, what is the management option? Of course, you have to use an antibiotic. In antibiotic, it should be the third generation cephalosporins, which are the drug of choice. Please remember, we have to give an antibiotic which can penetrate the central nervous system because this is meningitis, correct? So it should have a good CNS penetration. For that only, third generation cephalosporin is very, very helpful. Any example, a typical example, ceftriaxone. Typical example is ceftriaxone. Typical example is ceftriaxone, bacterial meningitis. Okay. Viral meningitis and all, you don't need to give any specific treatment. But if it is HSV infection, HSV1 infection, can you think of any antiviral drug which can be useful for a HSV1 infection? Any antiviral drug which can be helpful? Yes, acyclovir. It is acyclovir. Very good. It is acyclovir. For HSV1 infection, if you are strongly suspecting, then you can give intravenous acyclovir. Very good. Correct. Okay. Now you tell me for cryptococci. Suppose HIV positive patient, same thing. Cryptococci, I am saying. Which drug will be helpful in the management? Anybody? Which drug will be helpful in the management? Cryptococci. Cefixime? No. Cryptococci. Very good. Amphotericin B. Very correct. Okay. We have so many formulations of amphotericin like liposomal amphotericin and all. But at least you remember amphotericin B. That will be the drug of choice for cryptococci. Are you able to follow this, right? See, depending on the situation, you have to treat it. See, many viral infection, you don't even need to treat it also. But still, I'm saying HSV1 specific treatment is available in the form of acyclovir, bacteria third generation cryptococci. It is amphotericin. Now, there's no space here. Okay. You just leave the space for that next question. But below that, you remember any additional treatment you can give. Any additional treatments you can give in addition to antibiotics or antiviral agents. Any additional treatment you can use. You always have to use a steroid. You look at any case of meningitis which is being managed, they also add steroids. Okay, and you should give a very potent steroid which can cross the blood-brain barrier. Which is that steroid? It is dexamethasone. I think you can easily understand why we are giving dexamethasone. Yes, very good. Why we are giving dexamethasone? Very simple. Itis, meningitis. Itis means what? It is inflammation. Inflammation itself can cause a lot of problems in meningitis. So steroids are given for their anti-inflammatory effect. That's all. Very, very simple. Steroids are given for anti-inflammatory effect. I hope you're able to follow this. Correct? Steroids are given for the anti-inflammatory effect. That's all. So please remember, in bacterial meningitis, specific treatment has to be given, and along with the treatment, you don't forget to give dexamethasone also. Okay, because of its anti-inflammatory effect. Is that clear? Okay, fine. Now only one liner question. What is the most common long-term neurological problem from bacterial meningitis? Can anybody tell me? Most common long-term neurological problem from bacterial meningitis. So many problems can occur. Hydrocephalus can occur, edema can occur, seizures can occur. But the most common long-term neurological problem is always SNHL. What is SNHL? Sensorineural hearing loss. Okay, it is sensorineural hearing loss. That is what you have to remember. It is sensorineural hearing loss. Okay, that is why for all patients with meningitis, after you discharge the patient, you will ask them to come like 1 week, 2 weeks later. Which investigation should be mandatorily done for all these patients? Which investigation should be done in order to detect the sensorineural hearing loss for all these patients? You have to do this testing. What is the testing? Very good. BERA. What is that? Brainstem evoke response audiometry. Okay, brainstem evoke response audiometry. Okay, right. So please make a note of it. The most common long-term neurological problem is sensorineural hearing loss, and the investigation for the same would be BERA. And this has been asked as one of your previous year questions also. Please note it. One of your previous year questions. Which investigation should be done to detect this one? Okay, it is BERA. Okay, so please keep in mind. So that's about the topic of meningitis. I have taken it a little bit extensively because nowadays you are getting one sure question. Okay, whether it is pediatrics or in adult medicine, you are getting one sure question from meningitis in your exam. This is a must-know topic, especially this part. What is it? CSF analysis should be in your fingertips. You should know it very, very thoroughly. Because I've seen a good number of questions only with the CSF analysis finding. They ask you what type of meningitis you are dealing with, like that. Okay. Are you going to follow this slide? Yes. Yes. Okay. Okay. So that will be about the topic of meningitis, and with that we come to the conclusion of a big system, which is neurological disorders. I hope the discussion was useful to you. You were able to follow this. As I told you, my main focus of discussion will be about the important topics in each of the system. And even though it is very tough section, I try to simplify it to the extent which you can actually apply and recall in the exams. Okay. Don't try to study very, very tough concepts or very in-depth things about each of these disorders, because this is something which is very, very difficult chapter. So I try to keep it as simple as possible, and I try to touch upon the main points in each of these particular disorders. Okay, right. So now, I hope all of you have seen the MCQ question. I hope all of you have seen the MCQ questions which I had sent yesterday, or maybe it would have been shared in the morning today. Have you all gone through the questions? I am happy that some of you have already sent me the answers. Others, we are going to do the question discussion now. Okay, right? Just give me a minute or two. I will load all those questions in my app, and then we will resume the discussion. Just a minute or two, 1 minute or two. Meanwhile, you can see the questions and try to decide the answers. Okay, I will load it up in a minute or two. Yeah, sorry for that. Actually, this is an iPad which I'm using, so there is some issues with the shifting of that documents to another app. It is very difficult. Okay, so that is why it was taking some time. Sorry for that. So I hope all of you have seen the questions. So can we start the discussion? Yes. Okay. So here you can see many questions which I have given, or more like a scenario type question. Let us try to understand it. Like what are the important features given in the question? Try to formulate a diagnosis and then answer the questions accordingly. Okay, right? Yes. So first one, a 30-year-old female presents with multiple episodes of episodic headache for the past 4 years. It usually involves one half of the face, and it is associated with the nausea and vomiting. Okay, there is no aura associated with this. So now tell me what could be this particular condition. You have to discuss based on the features which are given in the question. What is that? It is a headache, right? It is multiple episodes of headache in a patient involving one half of the face. It's a unilateral headache. Along with that, there is associated features like nausea and vomiting. What is this condition? Any comments? Very good. Most of you have answered it correctly. It is a case of migraine. Can you see all the points pointing to the migraine? Very characteristic. What are they? It is multiple episodes, right? Usually multiple episodes. I told you at least you should have 5 episodes. Not with one episode you will diagnose this. Okay. Second thing, one half of the face is affected. That's also characteristic. Nausea and vomiting, associated features. All this tells you it is a case of migraine. Don't get distracted by this no aura. No aura simply tells you what is that? No aura simply tells you that it is a non-classical migraine. That's all. No aura will not tell you it is not a migraine. No aura tells you it's a non-classical migraine. That's all. And I told you non-classical migraine is the common type of migraine also. Can you all recollect that? Non-classical migraine is the commonest type of migraine also. I have told you this before. Okay, fine. So that will be about the answer for this question. It is option A. I hope all of you are able to understand this. Okay, cluster headache. The characteristic feature is that it will be surrounding the eyes. That is what. It is not at all a case of angle closure glaucoma. Entirely different presentation. Temporal arteritis. Temporal arteritis will have a headache in the forehead area. It will have a typically forehead area. Temporal arteritis will have elevated ESR. In your vasculitis disorders, they are going to discuss about temporal arteritis. Okay, it's also called giant cell arteritis only, where the headache will be in the forehead area, and sometimes you can even see a dilated temporal artery in the forehead region. Okay, dilated temporal artery in the forehead region. As of now, I'm not going into the details. Let me leave it there. Answer for this question: one is migraine. That's all. Number two, a 45-year-old male patient presented in the casualty, that means emergency room, with a 2-hour history of sudden severe headache associated with nausea and vomiting. Okay, so this is a sudden severe headache in an adult male. Okay, and he has neck stiffness, looking like a sign of meningeal irritation. But the rest of neurological examination is normal. This is very, very important. See, whenever we talk about neck stiffness, just now we discussed it can be a case of meningitis. But is it meningitis? No, because there is no fever given in the question. What are the points which are given in the question? Neck stiffness and a sudden severe headache. And one more thing, can you see what is written? Rest of the neurological examination is normal. It means it is not purely a brain problem like that. So what is this condition? Very good. This is a case of subarachnoid hemorrhage. Very, very important. Can you recollect subarachnoid hemorrhage? Can you recollect the subarachnoid hemorrhage which we have discussed? Can we have an idea about this? Yes. What are the things I told you? It will be a sudden severe headache, which is called as thunderclap headache or the burst headache of the life. Second thing I told you, there will be neck stiffness, but there won't be any fever at all. Third important feature I told you, what is that? Third important feature I told you is no focal neurological deficit. No focal neurological deficit. Okay, everything is given like this, so that is why it's a case of subarachnoid hemorrhage. I hope you can follow this. So can you see the first two questions were something related to headache. One was migraine related question. Another one was a headache related to subarachnoid hemorrhage. Now let me ask you one more question. this patient, we all know that subarachnoid hemorrhage commonly is associated with trauma, but this patient did not have a trauma. This patient did not have a trauma. So what do you think could have been the cause of subarachnoid hemorrhage in this particular patient? Is it a primary subarachnoid hemorrhage or a secondary subarachnoid hemorrhage? It is a primary subarachnoid hemorrhage. The probable cause of that could have been due to what? Rupture of barrier aneurysm. That could have been the probable cause in this particular patient. I am talking about the reason for subarachnoid hemorrhage. Okay. Are you able to understand this? Because a common condition is trauma related, but no history of trauma is given. So that is why I'm saying it's a primary hemorrhage, which is rupture of barrier aneurysm. I hope you can follow this. That is number 2 question. Number 3 question. A patient is being evaluated for aphasia. He is unable to name the objects properly. Unable to name the objects properly. This is an important clue here to begin with. Okay. However, his speech is effortless, but he has frequent errors in the choice of his words. What does these 2 lines tell you? This patient is definitely having aphasia. That is why he is having some speech difficulties. But can you see speech is effortless? What is the meaning speech is effortless? It's a fluent aphasia. It's a fluent aphasia. Okay, it's a fluent aphasia. There is a choice, sorry, there's a frequent error in the choice of his words. What is the meaning? He's not properly producing a word. He's not properly producing the words, or he is not able to understand what he is speaking. So what is this type of aphasia which we are dealing with? Is it a sensory aphasia or a motor aphasia? Definitely this is sensory aphasia. Sensory aphasia is the one which is actually a fluent type of aphasia. I think you can understand this, right? Sensory aphasia is the one which is a fluent type of aphasia. The rest of the neurological examination is normal. Now the question is very simple. Damage in which area of the brain would result in this type of aphasia? Simple question. First of all, dominant hemisphere or non-dominant hemisphere? It is always going to be dominant hemisphere. So this is out. Non-dominant hemisphere is out. All the other things are dominant hemisphere only. I told you left-sided. Okay. Now sensory aphasia will point towards which area? Wernicke's area. Correct. Sensory will be pointing towards Wernicke's area. Okay, towards Wernicke's area. Now we have to look up where is the Wernicke's area. I think all of you know Wernicke area is in the temporal lobe. Correct. Wernicke area is in the temporal lobe, posterior part of the temporal lobe. See, of course, the answer should have been only posterior temporal, but it is given together with parietal. So that is okay. Answer I'm going to mark as the posterior temporal and parietal lobe. Of course, it should have been only temporal lobe. That is what most of you are thinking. I can understand that. But best answer which will be fitting among the given options would be posterior temporal and parietal lobes. The most important thing is that it should be a dominant hemisphere. I hope all of you are able to answer this type of question. Okay, what we were discussing is simply we had interpreted that situation and come to the conclusion that it is sensory aphasia. Sensory aphasia means it should be Wernicke's area which is affected. Wernicke area is in the dominant temporal lobe. So that is why these 2 points made me think about option A as the answer. Okay. Dominant and temporal lobe made me think about the answer as option A. I hope you're able to follow this. Right. Okay. Next one is a very quick, easy, straightforward question itself. What is that? Which of the following is not a feature of UMN paralysis? We have just discussed UMN paralysis. What is that? Flaccid paralysis is a feature of what? UMN or LMN? It is a feature of LMN, not UMN. In UMN, you will have spasticity, correct? You will have spasticity or increased tone. Only lower motor neuron lesion, you have a decreased tone, which is manifesting as flaccid paralysis. Easy way to remember is like this. What is that? LMN, lower motor neuron lesion. The tone is low. Like that you remember. L for L. That's the easy way. Lower motor neuron lesion. The tone is low. That is what you can remember. All the other things, hyperactive stretch reflexes. That means deep tendon reflexes. Okay, I told you, deep tendon reflexes are increased in case of UMN, which is what is expected. Spasticity, increased tone. Just now I told you it's a feature of UMN. Muscle incoordination, or due to the weakness, there will be muscle incoordination. All these are correct points only, but flaccid paralysis is definitely a feature of LMN only. Okay, fine. Moving on to the next question. Which among the following is not a usual feature of right middle cerebral artery infarct? This is for you to answer. Which among the following is not a usual feature of right middle cerebral artery infarct? Can you get aphasias? Please answer that first. Can you get aphasias? Aphasias will be a feature of middle cerebral artery problem only, but not on the right side. It will be for a left middle cerebral artery infarction, right? It will be for a left MCA. The question is very clearly mentioning right MCA. It will not be the answer because left MCA only is supplying the left part of the brain and it will involve the speech areas. Are you able to understand this? So please make a note of this. Okay, right. Just a minute. Okay, so this is left MC. Okay, right? Yes, very good. That is what you are all saying correctly. Can you get the other? Can you get the other finding? Hemiparesis. What is the meaning of hemiparesis? one side of the body is weak, of course, you will get in case of the middle cerebral artery infarct. I think you can understand this. When one side of the body is affected, even the face also can be affected. So facial weakness can be present. This arteria, do you remember this? Middle cerebral artery is something which supplies the lateral side of the cerebral areas. Okay, in the lateral side of the cerebral area only is the representation for the head, throat, mouth, and all. So as a part of that, this artery also can occur. So everything can be possible except option A, aphasia, which will be not for the right side, it will be for the left side. I hope this is clear. Okay, moving on to the next question. Which of the following sensation is lost on the same side in Brown-Sequard syndrome? Okay, Brown-Sequard means something related to hemisection of the spinal cord. Same side means what? It is something which is ipsilateral. It is something which is ipsilateral. It is something which is ipsilateral. Okay, something which is ipsilateral. That is what you need to remember. So ipsilateral, what did we discuss? We have just discussed it before. Can I just go back to that? See here, ipsilateral. What is getting lost? Loss of dorsal column sensation, and one more is UM and weakness will be there. Contralateral, that will be loss of spinothalamic tract sensation. So now, if you look at the question, everything is related to sensation, right? Pain, touch, proprioception, and temperature. We have to choose ipsilateral. Ipsilateral means what? Something related to the dorsal column. Something related to the dorsal column. So pick up an answer. That is it. Very good. It is a option C or proprioception. Because we all know pain and temperature are related to spinothalamic tract, which will be on the contralateral, opposite side, correct? And some of you can have a problem with this touch area. Remember, touch can be two things. Touch can be either a fine touch or it can be a crude touch. Okay, are you able to understand this? Some of you can get confused. Here, the examiner has not correctly mentioned fine touch or crude touch. So it is safe to ignore these type of options because we all know that fine touch and the crude touch. Where is fine touch related to? Question. Where is the fine touch related to? Where is the fine touch related to? Spinothalamic tract or the dorsal column? Simple question. Yes, fine touch is related to the dorsal column, whereas crude touch is related to the spinothalamic tract. Here they have not mentioned fine touch or crude touch. So if I mark that option, you are going to be wrong because the examiner could have mentioned anything, fine touch or a crude touch, right? So it is always safe to ignore those particular options. I hope all of you are able to understand this. Why I am not saying touch as the answer. Okay, this point should be very clear. Okay, so that will be for question number 6, which is option C. Moving on to question number 7. A 80-year-old female patient presents with a progressive loss of memory, difficulty in recalling names, difficulty in speech, and not able to perform desired tasks. Which pathological feature is likely to be present? Look at the age 80 year. It is something a disease of senility, very, very old person. Okay, senility. And you can see what are the important things which are given. Loss of memory, which is amnesia, obviously. Then what is the next one? Difficulty in recalling the names. What is that? Anomia. Difficulty in speech. What is that? Aphasia. As well as inability to perform desired tasks. What is that? Apraxia. And you can see 80-year-old patient with so many manifestations starting with A. What is that? The disease also starts with A. What is that? Very good. Alzheimer's disease. It is Alzheimer's disease, correct? And Alzheimer's disease is a neurodegenerative disorder due to accumulation of abnormal proteins, I told you. Your answer is going to be over if you know what is the abnormal protein which accumulates in Alzheimer's disease. Very, very straightforward. Very good. Most of you got it correct again. It is beta amyloid protein. That's all. Now, coming to the question which asked as a homework, in Down syndrome, why do you think there is pre-senile Alzheimer's disease? I asked that question. Okay, it was something related to Down syndrome is what? Down syndrome is trisomy 21, where they have 3 chromosome 21. In chromosome number 21 only, you have something called APP. What is that? Amyloid precursor protein. Okay, I was happy that some of you already sent me the answers. Others, I'm sure that you must have looked upon it. This is the explanation for that. What is that? APP, which is amyloid precursor protein. It is something related to what? Production of amyloid. So you think like this, this patient is having 3 copies of chromosome 21. Normally we have 2 copies of chromosome 21, but this patient is having 3 copies of chromosome 21. So there is an increased amyloid production. And because of increased amyloid production, when it gets deposited in the brain, it will result in pre-senile Alzheimer's disease. That is what is the explanation for a patient with Down syndrome having early onset of Alzheimer's disease. I hope you are able to follow this, doctors. Yes? Okay, fine. That will be question number 7. It's a straightforward Alzheimer's disease patient, which is given in the features. Question number 8. A patient presents with headache and nuchal rigidity. Nuchal rigidity is a sign of meningeal irritation. You have to think about meningitis in this particular question. And that is why they have done the CSF analysis also. Now, look at the CSF analysis. What are the findings you are having? Normal protein, normal glucose. Cell count is 50. cells are definitely increased because the normal cell count is only 0 to 5. Here the cell count is increased, but presence of lymphocytes. So which condition of meningitis you will get normal protein, normal glucose with increased lymphocyte count. Very, very straightforward again. It's a viral meningitis. Are you able to understand this? Right? Very good. Most of you got it correct. It's a viral meningitis. This type of question surely you are expected in your exam. So please don't make mistakes here. For you to know this particular question, this particular CSF analysis picture or this table should be known by heart. Okay, there is no reason to forget this. It should be known by heart. This type of questions are highly expected in your exams. Okay, fine, very good. Move on to the question number 9. Which of the following is the most common cause of neurological deterioration in the case of subarachnoid bleed? I have told you, most common cause of mortality, as well as morbidity in a patient with subarachnoid hemorrhage. What is that? It is nothing but vasospasm. I told you this. It is a vasospasm. So the answer is option B. Very, very straightforward question only. In order to decrease the incidence of vasospasm only, which drug you will give to decrease the incidence of vasospasm? We give nimodipine. You remember this? We give nimodipine to all patients to decrease the vasospasm, thereby decreasing the mortality and morbidity in a patient with subarachnoid hemorrhage. I hope all of you can follow this. So for question number 9, the option B will be the answer. Okay, right. Very good. Question number 10. A 50-year-old female presented with a pain, numbness, and impaired sensation over half of the face, along with ataxia, nystagmus, dysphagia, and hoarseness of voice. Pain and thermal sensation over the opposite half of the body are impaired. Horner syndrome is present. Likely causes thrombosis. Thrombosis means like occlusion of which blood vessel? Any comment? Okay, let us look at the questions. Okay, let us look at the question. See, thrombosis is something which is like occlusion. Occlusion can result in the stroke manifestation, correct? Occlusion can result in the stroke manifestation. That is what we are talking about. And based on the findings, you have to tell what is the condition. Let us see. Patient has impaired sensation, pain, and numbness on the half of the face. See, you all know that face sensations are related to the sensory part of the fifth nerve or the trigeminal nerve. So can I say that the trigeminal nerve sensory part is getting affected? That is why there are impaired sensation from the half of the face. That is one thing. Next thing, ataxia, nystagmus may be related to the 8th cranial nerve. Think like this. 8th cranial nerve. Okay, right. Nystagmus not, but maybe ataxia. Okay. Then dysphagia, hoarseness of the voice are related to what? Dysphagia, hoarseness of the voice are related to the 9th and 10th cranial nerve getting affected. Of course, motor component only 9th and 10th cranial nerve affected. And also, pain and thermal sensations on the opposite half of the body are affected. Pain and thermal sensation affected means what is the tract which is affected? Spinothalamic tract which is getting affected from the opposite side, contralateral. So can you think of any condition where all these nerves, 5th cranial nerve, 8th cranial nerve, 9th and 10th cranial nerve, along with spinothalamic tract is getting affected? What is this condition we are dealing with? The condition is very clearly a case of lateral medullary syndrome, correct? Do you all recollect that? Lateral medullary syndrome. And now the question is very simple. Lateral medullary syndrome is due to thrombosis of which blood vessel or occlusion of which blood vessel? Very, very simple. What is that? Very good. Among the given options, I will choose vertebral artery. I told you 2 things are possible. One is vertebral artery, another one is pica. Here, pica is not given. In fact, I told you most of the clinical textbooks are giving vertebral artery occlusion as the number 1 cause of lateral medullary syndrome. So we will go ahead with that. I hope you are able to follow this type of question. First, you have to understand that it is lateral medullary or Wallenberg syndrome. Then you have to tell it is due to occlusion of the vertebral artery. Clear? Very good. Most of you have got it correct again. Okay. A young male develops fever followed by headache and confusion, focal seizures, and right-sided hemiparesis. Right-sided limbs are not functioning. MRI shows bilateral frontotemporal hyperintense lesion. What is the most likely diagnosis? See, headache, confusion can be seen in so many things. We cannot make any diagnosis based on this. But look at the clues. Focal seizures. Focal seizures means, sorry, I forgot this one. What is it? Fever. Fever means it's an infection. Which is a condition where you have fever and focal seizures. It would be a case of encephalitis. That is what I told you, right? If it is meningitis and all, you will get what type of seizure? You will get generalized tonic-clonic seizure, not focal seizures, right? Even one half of the body only is affected, right? Hemiparesis. That also tells you it is encephalitis. Encephalitis, see, this is a feature of lobar involvement, right? This is a feature of cortical lobe involvement. Correct? That is why only right hemiparesis is getting involved, okay? And now you have to localize where could be the problem. It is clearly mentioned that there are frontotemporal lesions on the MRI. Because I told you, all cases of encephalitis, you have to perform MRI. Do you remember that? I have told this in the discussion. So MRI has been promptly performed and it shows frontotemporal lesion, especially the important word is temporal lobe is getting affected. So which of these organisms? Acute pyogenic meningitis, which is usually due to a bacteria, will it cause that particular problem, or viral herpes simplex, or neurocystic sarcoidosis. Of course, carcinomatous meningitis is not a condition itself. You don't need to worry about that. You have to choose your answer within the first three things. What is that? Very good. It is classical of herpes simplex encephalitis. Herpes simplex only because it has got a propensity to involve which lobe? I have already told you this, temporal lobe. It's very clearly mentioned in the question also. That MRI shows definite lesions in the temporal area, so answer has to be temporal lobe. Answer has to be herpes simplex encephalitis. I hope you're able to follow this. Right. Now, question number 12. A patient presented with right-sided hemiplegia while on warfarin. What should be the initial investigation to be done? Any comments? See, warfarin is an anticoagulant, correct? Warfarin is an anticoagulant. What is the side effect of anticoagulant? What is the side effect of anticoagulant? Suppose the patient has taken lot of or overdose of that anticoagulant. What could be the side effect? It could result in bleeding. That bleeding could have resulted in this hemorrhagic stroke. That bleeding could have resulted in a hemorrhagic stroke, which could have been manifesting as right-sided hemiplegia. Are you able to understand this? It could be due to warfarin itself, bleeding could have happened, and that could have resulted in a hemorrhagic stroke and the patient developing right-sided hemiplegia. So now, whatever it is, we are suspecting stroke in this particular patient. What should be the initial investigation? Very, very simple. Always, I told you, emergency situation in the involving the neurology. Any neurological problem, emergency situation, the first thing you have to do is non-contrast CT. That's what I told you. I hope all of you can remember that. Non-contrast CT. And I told you the role of non-contrast CT in the case of stroke is to exclude hemorrhage as a possibility. If there is no hemorrhage on the non-contrast CT, then it is a ischemic stroke. That is what I want you to remember. Correct? Are you all able to understand the wordings of this question? This question was telling you about presentation of the stroke, but in association with warfarin, you have to think about hemorrhagic stroke. So in a case of hemorrhagic stroke, what is the first investigation you will do? Whatever be the stroke, first investigation always will be the non-contrast CT. I hope you are able to follow this. Clear? Okay. Last question. All of the following are true about Weber syndrome, except. All of the following are true about Weber syndrome, except. Weber syndrome is something related to the midbrain stroke syndrome, right? It is related to midbrain stroke. And can anybody comment on the answer? Will you have oculomotor nerve palsy? Definitely yes. You will have oculomotor nerve palsy because that is what is related to the midbrain area. When oculomotor nerve is affected, the eye movements are getting affected. Definitely the patient will have diplopia. And what is the next one? They will also have involvement of corticospinal tract. You remember that? And I told you, it is the opposite side limb weakness will be there. So contralateral hemiplegia definitely will be present. So what is the answer? Facial nerve is no way related to that midbrain area or the midbrain stroke, and that will be the answer for this question. Okay? It is not associated with the facial nerve lesion. Facial nerve is more related to what? Facial nerve is more related to the pons area. That is what, not midbrain area. Clear? Are you able to follow this, Dr. Slide? So that is what is the MCQ discussion in the neurology section. I think almost like 20-25 minutes we have discussed this MCQ. But why it took a lot of time is because most of these questions were clinical scenario questions. First, we need to interpret the clinical scenario, and then we have to decide on the answer. So that is why this type of question discussion took a long time. But I hope it was useful for you. It is like a summary of whatever we have discussed over the last one full day. Okay. Clear, everyone? Okay, nice. So please read this chapter properly. That's what I can tell. This is a very, very important chapter. It's a very important chapter for your exams because definitely 5 to 7 questions will come from this particular section. Okay, right? And at least try to understand the core concepts. Okay, at your level, for the screening exam level, it is not important that you need to know each and everything of neurology. It is simply impossible, right? But whatever I have taught you is like a very concise version only, but based on the important topics. Okay, that is what I had mainly focused on, and I feel a good number of that 5 to 7 will come from our discussion itself. And I hope you get all those questions correct. Okay, right? Because in the end, all these things will contribute to your final marks. Okay, and I think these all should be your strong areas. Because whenever I start teaching medicine, okay, I don't teach it regularly medicine. First of all, let me tell that I usually teach pediatrics because I'm a specialist in pediatrics only. But whenever I teach medicine, usually students have a hesitation. They say that medicine is a tough subject, so I usually tend to leave it during my preparations and all. But all I can say is only this. What is it? It is definitely a tough subject, but at the screening exam level, basic questions are only expected. Okay, and I don't think it is very difficult to understand these basic concepts and apply it in the questions. Okay, and that is what exactly I have tried in the last one full day. I hope you are able to take something out of it. And once you read it properly, you will get more grip on the subject, and that will help you to solve questions more confidently and more easily also. Fine. Okay. So with that, I'm ending the topic of neurology for your exams. We will have the lunch break now, and after the lunch break, we'll start with the cardiology section. As I told you, cardiology, a very small part only will be discussed. The main part of cardiology will be in the next class only. The date is not yet decided. I will tell you the date where we are going to discuss. Okay, but before that, we will have the break now. Now the time is around 1:30. Okay, by 2:15 to 20, can we start the session? Okay, okay, fine. So I will start at the time. Have a lunch and we will start with the cardiology session after this. Okay, thank you.